Said something nicely.
Good morning. We're going to go ahead and call our meeting to order, the Mohave County Employee Benefit Trust, our annual trustee renewal meeting. We're going to begin with a call to public. Is there anybody who wishes to speak to the trustees? Okay, hearing none, I'll go ahead and close the call to public. Opening remarks, I would just like to first of all say thank you for all being here. I understand the importance of this meeting. If I misstep, I trust staff will somehow, make a face at me or something, and I'll get it real fast. We have a very important meeting, so obviously the subject matter today is very serious. I want to thank all of you for coming. Certainly want to thank, was it the hospital that provided the breakfast this morning? KMRC or whoever provided the breakfast, thank you. Okay, very much appreciated. Those are my opening remarks. Mr. Hatz, did you want to have some opening remarks, please?
Sure. Good morning, everyone. Glad to be back. We have a lot in store for you today, so as always, feel free to answer questions or ask questions. We'll try to answer them. But also wanted to thank the following vendors for their sponsorship, Oaks and Navitas. Thank you very much for everything you guys do. We have a lot of information to go over today. I think this is going to be a positive agenda. Welcome, Mr. Chair, for your first meeting. I think this will be a good one for you to start off with. So appreciate you having here. Yes, it'll be very good. And again, we have a ton of information to go over. Don't hesitate to ask questions, but a lot of positive information. Looking forward to this meeting today.
Thank you very much. We're going to go ahead and go into our first item, which is the medical claims review and the overview of the ETnet network and Teladoc. Rick, I can't pronounce your last name.
Really? You can't?
Yeah, really? No. I'm assuming that J was silent, but I wasn't sure.
It kind of is, yes. Yes, good job. So my name is Rick Zythamo. I'm the account director at Meritain Health, and we're the ones that administer and process your medical claims. We also provide you the Aetna WRAP network, which is all your providers outside of the state of Arizona. And of course, we do manage the Teladoc. I was told that, though, in the interest of time, and I don't know who's going to be putting up the presentation. Do I have to do it up here by myself, or is it on there? You guys see it? Anyway.
Well, there's somebody in the back room, so.
Okay, open the work session. Okay. Is it touch? No. Sorry, technical difficulties here. Here.
Work session.
Work session. Work session, medical claims. Then I have this.
So, John, I assume it's this presentation?
Yes, that's the presentation.
I think
there.
all the trustees.
As long as you have it,
it,
I'll just have to look at it myself here.
Here we go. You're up.
Yeah. Okay, there we go. All right. And out of there. Clicking through it. It's always fun being the first presentation. Okay. I was told, in the interest of time, to keep it short. So I do have a lot of slides in here, a lot of reports that I like to provide you all. But what I'm going to do is really focus on the two slides that are the executive summary to go over, because that's really a high level of what's going on. But please, if there's any questions that you have, like looking at other reports, we could talk at lunchtime when we have that break. But for right now, like I said, I'm just going to keep it high level for all of you. Right now, what we're going to be doing is reviewing calendar year 2024 and as it compared to calendar year 2023. This is not based on your plan year, so just so you know that some of the numbers with your financials might be a little bit different than what we're showing here, but we want to give you a full year's worth of claims just so you see what's going on. What we do is when we try to figure out what's going on with your medical claims, try to understand trend and things of that nature, there's a lot of little things that could impact what's going on with your plan. For instance, so we want to give you the demographics. If you have members that are added to the plan, you might see your claims costs go up because you're adding people to the plan. In this situation, we saw just a slight decrease in your membership over the year, 1.3% to be exact. I have listed here those that your retrospective risk score and your prospective risk score. Usually you want to have it a little under 1 because that basically is showing that your claims that you had in 1 year, the predictability of them going to be in the next year. If it's under 1, that means that you're actually running better. With it being around 1, it means you're about going to run about the same. So we do see that you're still staying about 1.06 for your retrospective looking back, but your prospective, it went down a little bit to 1.01. Again, just put a concept of what that means. It means that maybe some of your sick members probably came off the plan. That's why the prospective is slightly lower, but it wasn't enough. Like maybe you lost one sick person, but then you probably lost a lot of healthy people as well. What we also try to do is normalize things by looking at your per member per month. So if your membership goes down, you think, okay, how much am I spending per member per month? If that goes down, then that's good. It means that probably, the healthy people are still on the plan. And as we see here, you saw about a slight decrease as well of negative 2.5%. And the great news is that you're about 9% lower than our book of business for how much you're spending per member per month. The one concerning thing is that you do have where the spouse is on the plan, so how much you spend per member or per spouse per month is about 26% higher than it was in the prior year. And so what we saw was in 2023, you were spending about $768 per spouse per month, and in 2024, $970. So that's quite the increase. Our book of business for spouse coverage, though, is about $892. So you're a little bit above for spouses on how much you spend for spouse per month. Your employee cost share, just saw a little increase there. Probably a little bit of a migration of people going to the high deductible health plan. As you can see over there in that left square, you only have about 22% people that are in that, but you probably had a little bit more people that went. And so that's going to show that you're going to spend, the member's going to spend a little bit more because they're on a high deductible health plan compared to those that are on the EPO plan. Looking at your high cost claimants, you had about 19 members that had claims over $100,000. Which represents about 33%. So you just have basically how many you can count twice on your hands. That is almost 1/3 of how much you're spending on your plan, and that's at $4.55 million. When we look at and focus at the top 10 high cost claimants you have, 3 of them were repeats from the prior year. They were in fact 3 of your top 5, and they're still on the plan. So they're probably going to be, because of their chronic health illness that they have, will most likely be in 2025 on your high cost claimant list as well. Looking at your medical trends, although your membership went down, we did see your claims utilization claims received was about 2% higher. We had about almost 3% in claimants. So again, membership went down, but you still had members that are using the plan more in 2024 than 2023. But the good news is there's a reason why your per member per month is down 2.5% is because the amount that you paid is about 6% less in 2024 than 2023. And a lot of that has to do with claims negotiations, the network utilization. In this next box, you'll see that you actually had an increase in your discounts. And so Blue Cross Blue Shield's here. Rachel will talk about what Blue Cross Blue Shield has done in 2024. I know on Aetna's side, we had a lot of providers that went, their contract was up, so we did some negotiation with that, and so we saw some deeper discounts at some of those providers, especially those in the Nevada area. So anyway, the other thing about Aetna, you saw your average discount is about 79%, which is great. For what's great about the Aetna network is you pay per employee per month. You don't pay a percentage of savings. A lot of networks that you try to negotiate with outside of Blue Cross Blue Shield, they'll probably want to do some sort of negotiation, and they'll say, average, we'll charge 15% of how much we saved you. Now, if Aetna did that, it would have cost you about $642,000, but because it's a PPM, you can budget for it, and you only spent $74,000 in that year. So for every dollar you spent, you saw a return on investment of $58 for every dollar you spent for that network.
I have a question for you, John. On the medical trends, the preventative services were down significantly. Is that a good thing?
No, that is not a good thing. And I was just about to touch on that. So I appreciate you bringing that up. Is that, yeah, we see this decrease in the preventative services of 12%. That is, unfortunately, we do not want to see that, right? Your members, the best way to try to keep your long-term cost down is for those people to make sure that they're going in and having their services done. Their annual exams, mammograms, colonoscopies, everything that's covered by the Affordable Care Act that's done for free. So it doesn't make sense to not do it because it is free for them to utilize without any penny coming out of their pocket. So we do need to get more communication out to your members to make sure that they're doing the preventative services. Any other questions before I move on?
I do have a question. Do we know how many of the preventative services are done at the time of the fair that they have, the wellness fair that they have? Usually, I think it's up here, and they do all the screenings and stuff. Do we know what percentage of the employees are utilizing that versus?
I think that Tori usually has those numbers for the wellness, and so I don't know if that's going to be in your wellness presentation, but I don't have that information because all I get is the stuff on the claim side, and then if it comes in, I don't know unless I look at data service and it's all on the same day. But I did show that mammograms overall, even if they're not at that fair, then your mammograms are lower than they were in the prior year.
Okay, I can wait for the answer. I know that it's later in our
Yeah.
meeting, but I thought maybe you had that information.
Yeah, I'm sorry, I don't, because I don't manage that part of the program. So, any questions before I move on? Okay. So this next slide, one of the most important boxes on this slide is the top diagnostic category because it really impacts and reflects what is driving your costs. And if it's something that we could probably, again, if there's preventative services out there to try to catch these things. The endocrine, nutritional, and metabolic, usually what falls under there, you're like type 1 diabetes and type 2 diabetes, which type 2 diabetes is one of the cost drivers, but not as much as your thyrotoxicosis. Try to say that 3 times fast. It's your thyroid gland that produces too much of the thyroid hormones. And so what it is that these people are getting infusions to treat this, and they're not very cheap. So that's the one thing that's driving that cost, as you can see. It's 9% higher than it was in the prior period, and it's 320% than what we're seeing on our book of business. So that's, and these are the people that you will see on your top 10 high cost claimant list as well, because they're the ones that are impacting your plan. Your musculoskeletal, the good news there is that we've seen it drop 24%. The back pain and osteoarthritis of the knee are the drivers, but the fact that it's going better might reflect, and I've seen your claims, Hinge Health is making an impact on that with people doing the things where they don't have to go to a physical therapist. They can do everything in their home, and it's helping your musculoskeletal claims come down. So it's a good sign there. Factors influencing what usually drives this is going to be your chemotherapy costs. But as you can see, we saw a 35% basically drop from your prior period, and it's 38% lower than our book of business benchmark. The reason for this was, again, back to what I was talking about with claims negotiations and things of that nature. We did get a refund on one of your high-cost claimants of about $372,000 for the, let's see, it was an adjustment of the orthopedic aftercare results. So we were able to get a claim renegotiated, and so that brought more money back to Mohave County. And what it actually did was it was somebody that hit stop loss, and so the refund went to the stop loss carrier, but that's going to help you when your stop loss is going to be renewed, because it's not going to be a high increase. It's going to actually be better because it's actually showing that you had lower costs for your high cost claimants. And then digestive went down about 9.7%. It's higher than our book of business by 13%. The thing that's driving that is hernias, which is really interesting. So a lot of hernias going on in your population for some reason, and that's the number one driver. And in fact, it's double what the next thing was in line for it. So again, going back to preventative services, they do the little cough, thing. So maybe we need to get people to make sure that they're getting checked for hernias. And then finally, your I'm not even trying to say that one. Chronic kidney disease. That's why that's up about 60%. So you do have some chronic kidney disease, people going through dialysis, and that's going to drive the cost for your genitourinary system. So, sorry. The next box we have here is your claimant distribution. We already talked about those 19 members that were about 1% of your population that represent 33% of your costs. We have another 36 members with claims over 50,000. So that means about half of your population, just over half of your population, or not population, 3% of your population is representing over half of your costs for what you're seeing in claims. Good news, inpatient trends. We're seeing that your claims, cost, and everything for inpatient is down. So that's a great thing. The only thing that we're seeing that's gone up is your cost per day, and that's due to medical inflation. A lot of these hospitals had to hire nurses. They're short-staffed with doctors, and a lot of medical equipment is very expensive nowadays, and so you're going to see higher costs in the hospital. But fortunately, if you have less people going in the hospital, you're not going to see as much of an impact to your plan. Your outpatient trends, we have the thing that's driving that is your drug administration is driving that increase, which back to the thyroid people and chemotherapy. So those are the things that are driving the cost of your outpatient trends. The good news, though, is that your claimants are down about 7%. Unfortunately, the amount you pay per visit is 10.2% because of those high-cost drugs that are being administered. Your ER trends, good news is that people aren't using the ER as much as they were in 2023. All your numbers are down there. Keeman Healthcare is your highest utilized, which kind of makes sense. And then the exceptional healthcare in Bullhead is your highest cost per visit. So if you have to go to an emergency room, don't go to the Bullhead one. I'm just kidding. But, I don't know if you want to travel to Kingman or Lake Havasu City, but that's just some stats I want to provide to you. And then professional trends, we're seeing these are all going negative. Back to that point of preventative services, you don't want to see those going down. You want to see those going up because that means that your members are going in for their preventative services and things of that nature. So we do need to make sure oh, and I was wrong about the mammograms. I actually had that flipped around. All the screening is down for all your preventive services except for mammograms. So I apologize that I said that before. I just remembered that everything was down. But mammograms, though, are staying up, and it's probably because we do the on-site services. So that's probably a good thing. So if we can get more on-site services, we might see those preventative services go up. And I'm just going to leave it at that for the time being. I'm not going to go into any other reports because of the interest of time. So if anybody has any other questions, I'd be glad to address them now. All right. Thank you. I'll just get it.
Good morning. It's Rachel. Thank you for asking. It's the E. Since I can remember in kindergarten with crooked glasses, it's always Rachel. But good morning, Mr. Chairman and trustees. Happy to be here today. Rachel Martin with Blue Cross Blue Shield of Arizona, and I'll take you through the deck. And we'll kind of make this short and sweet because I have the small portion of today's discussion. Here's your Blue Cross Blue Shield team. I lead our team here at Blue Cross Blue Shield. Mike Greger is my VP of Sales. Liam is my day-to-day and works very closely with our Maritime partners on any claim network concerns that we might have. And Washington also works alongside of me, and he's building up our verticals in our public sector area here in Arizona. In the state of Arizona. So happy to be here. I've been with you guys since I've relocated here from Michigan, so it's good to see some familiar faces and good to welcome new ones. As you all know, Blue Cross Blue Shield of Arizona is a nonprofit Blue Cross Blue Shield plan, and as such, we are able to contribute foundation dollars. We have a Blue Cross Blue Shield Foundation. Every year I talk about this because I do feel that there are opportunities, as you folks are all pillars within this community. You know people in communities, and you know folks that might have resources or their own nonprofit outfits where we can help support them. At our Blue Cross Blue Shield Foundation, we focus on four pillars, if you will, and that would be chronic health conditions. We know that diabetes and chronic kidney disease are both on the rise for Arizonians based on our data that we see. We have 1.5 million members insured with Blue Cross Blue Shield, so we have a lot of data, and that's what's telling us is driving healthcare costs in this particular state. Health equity is social determinants of health, so for any of our Arizonians that might be in a lower poverty type of lower poverty setting, or maybe they have access to care or they don't have transportation. We work with community outfits that that can support travel to and from providers so that they can obtain their care. Mental health, this is a big one. Post-COVID, this is one of our flagship conditions that Blue Cross Blue Shield of Arizona is standing behind. I'll talk about more of that in a second. And substance abuse disorders. So we know with the opioid crisis that ran rapid here in the state of Arizona. And for any and more information about our overall Arizona Blue Foundation, I've hyperlinked our link directly here at the bottom. And as a Blue Cross Blue Shield employee, I've worked for Blue Cross organizations for 27 years, and it's part of my cloth and my pride that we are able to reinvest in the communities that we live, work, play, and it's just one of those foundational things that means a lot to me. So I am proud to stand up here today and say we've served over almost 450 community outfits within the state in every single one of our counties, in all 15 counties. And we've supported over $20 million to those entities since we started the foundation in 2018. I talked about mental health. It continues to be a flagship for us. We have expanded our network by using virtual providers because we knew in rural areas such as Kingman, Lake Havasu, Bullhead City, that there are access to care issues in a traditional brick and mortar setting. But what we have seen through our data is that Arizonians have an increase in anxiety, depression, and unfortunately suicide. We have reinvested over $5 million in the last 3 years for organizations that help support these types of conditions that are on that far right. So access to care, suicide prevention, youth mental health, and the intersection of behavioral health and substance abuse. We know that if we can help in that outfit, we want to certainly help. We have funded 95 grants specifically related to behavioral health, and we have served almost 1 million people tapping into these communities and these organizations within the state of Arizona. Through all 4 of our focus pillars that I talked about, we have invested $168 partnerships. Over 2 million services have been provided. These are people that can walk off the street to obtain these services. We have supported almost a million services in that security and food security. That's one of the trending items that we've seen in the data is folks that cannot obtain food for their own families. It's a growing trend here in Arizona. And we have supported over 800,000 awareness and prevention campaigns, whether it is standing at a farmer's market, whether it is supporting an event, whether it is a LinkedIn campaign, or if it's a partnership with sponsorships. So again, if you are aware, I'd be happy to talk more about any of the access to these tools, but I have linked the grant process. And right now we are in the application through the end of March. So now is the time. Here are just a couple of foundation grantees for 2024 that we have supported. Here in Mohave County, we've supported the Haven Center, Arizona Youth Partnership, Local First for Arizona, and all of these programs either help with, like for example, Haven is Lake Havasu School District for food insecurities. Arizona Youth Partnership is the prevention of behavioral health and substance abuse. And then Local First Arizona is actual tribal and rural populations and communities and giving them the resources on how to grant right. So that's exactly what we're trying to support here in the state of Arizona. So one thing too that you may have heard is in last year we had some Phoenix Children's Hospital and Blue Cross Blue Shield were in the news quite often because we were standing on the affordability stand of, hey, let's meet in the middle. And we have secured a 3-year deal with Phoenix Children's Hospital. It's actually your number 5 in your utilization, as I could see on page 25 from Rick's report. So you had about 178 claimants. Phoenix Children's Hospital and Blue Cross were out of network for a period of time. We have since resolved that network negotiation in February 8th of 2025, and we've been working with our TPA partners with Ameriven to reverse those and pay those claims at the in-network level for any and all of those claimants so that there's no disruption or gap to their care. So that was a big win for us, but where we unfortunately had to go out of network because of the costs and of some of the requirements and rules that was going back and forth in any negotiation process. But we secured the deal for 3 years, $80 million. So it's not a small piece of change, but we know that the value of that is to maintain affordability so we don't push that off to our members and or our own risk as a fully insured organization. Okay, so I'm going to quickly get into numbers. This is the part where I manage the Arizona only network. Rick takes on any of the outside, whether you're going to Vegas or California for services. So for the time period of 12 months, we had 39.7 million billed to Blue Cross. Our deep contract, our provider contracts allowed amount is where it's at. So 14.1 is what we allowed for those services, which provided over a $25 million savings to the trust. That equates to a rich 64.4% discount, and our state average is 64%. So we are right in line with the state average. And we value that 1 percentage point of that 64 equals just about 400,000. So variance, when you're looking at competitors, we feel that our brand, our network, our provider discounts are pretty straight for us to carry our number 1 market share in the state. When I look at this slide, I like to take that savings number of 25.5 million and see where does it overlay? Is it inpatient? Where are we getting the biggest savings? Is it inpatient, outpatient, professional? And for Mohave County, as it was last year, outpatient services is driving the savings. So 57% of the 25.5 million was was your outpatient services, and that equals $14.5 million in savings. So the discount specifically, so we have discounts per line of service too. The discount specifically for outpatient is 62%. Again, that equated to about 4.5 million in savings for you all. And it was a 67% increase. So coming behind Rick, I can see that outpatient services and high-cost claimants receiving those outpatient infusions is driving that utilization increase. So with that, utilization increases, savings increases, and claims increase. So that's what we're seeing here. 67% increase to outpatient savings, where last year was 8.7. 14% increase to outpatient claims. Last year was 2,500. This year it's 2,800. And a 19% discount from last year, 52% to 62%. Any questions? Okay, I'm going to keep moving really quickly. The value of the Blue Discount Advantage, I just like to share this amount for the savings that we're providing the trust, the network value that we're bringing to the trust. The AZ access fee is what the county is paying me to tap into those deep discounts. So when those numbers are above what you're paying me, that's a deal. So we could see the trust is paying $185,000, and we're bringing to you guys a $25.5 million in savings. This is my historical trend. You can see we're in the green. Blue Cross is using a medical inflation of 10%. In my opinion, that's a little high, but I think national averages are around 7%, but our actuaries are using 10. And over this 5-year period, you see that we have maintained a very strong discount position for you all. You can see from 56% all the way up to 64%. And then this is what I like to call the money shot because it pulls everything in together. So through the 12-month, most recent 12-month period, we have been able to successfully provide you a 64.4% discount on that almost $40 million of claims that were billed to Blue Cross. The savings of $25.5 million were driven by your outpatient services that were obtained by your membership. And then lastly, the claim distribution. So it's amazing to me when I see these numbers that just for one customer, 19,000 claims came in for a 12-month period. And that was driven by your professional claims, being PCPs and specialists. The chart on the very bottom is a breakdown. You can see these very rich discounts by the service level. So inpatient, 72%. Outpatient, 62%. Professional, 65%. Those are bang up, either at or near the average of 64%. So very rich discount position for us. And then just the summary comparison to last year's 28% increase from billed, 9% increase from the discount, 40% increase in savings, and a 4% increase to the claims we've seen from year over year. And I think that's it. And I'm under the 50. It is a lot. Welcome to my life. If you've got any questions, though, Mr. Chairman, I'm happy to address those. And I would really love to come back here and share some successes with any of the communities that you might be involved with through the foundation. You're welcome very much.
Good morning. I'm Lisa. This is Brian, and we are going to talk to you about your pharmacy spend. So let me go ahead. This is an executive summary. So we put this in the deck because, as you mentioned at breakfast, there's a lot of data in here. So if you ever want to go back to the deck and just see the high points about the pharmacy benefit, you can refer to this slide. So you'll see in the bottom in that small writing, the time frame that we're looking at is 2024 over 2023. So just thinking about that time frame, what the plan paid was for prescriptions was 1.7 million. The trend, which means how did it increase or decrease over the prior time frame, was only 1.7%. So that's great. You didn't increase much from the year prior. And then the plan paid per member per month was $68.73. And what that means is we take that plan paid, we divide it by the months that we're looking at, and the amount of members that you have. And that gives you a figure that can be normalized to compare to other clients. So you can see $68.73 was about 3% more than the year prior, which is not bad at all. And then the benchmark is other clients at Navitas that are similar public sector kind of clients. Their overall average was $111.43 for per member per month. So you're doing very well compared to our book of business. On the lower left, that's your specialty percentage of plan paid. Specialty are those expensive drugs for chronic conditions and really drives a lot of your pharmacy spend. So you had 49.2% of the prescriptions filled were specialty prescriptions. And compared to the benchmark, you're about a little bit higher, but very close to what we see in our book of business. The generic dispensing rate, we want that to be higher because we want generics to be dispensed. They're less expensive. So your generic dispensing rate was 87% over the benchmark of 84%. So you're doing great. So just overall, everything looked very good.
So I have a question on the generics. Do we mandate the use of generics in some cases?
Do you want to?
We don't mandate generic use. It's just based on what the doctor's prescribing.
Okay, the next one here is a little busy. I'll just go through the middle column there, current period. So we're just looking, did your average invoice membership increase or decrease? It stayed about the same. Of those members, those utilizing was 70.3%. So that's how many members actually went and filled prescriptions in that time frame. How much did the member participate in the cost share? About 14% of that. And then total scripts for the year, you had 15,970. So that's a good descriptor of how many prescriptions were actually filled. And then utilization days supply per member per month. That means when the members go to the pharmacy, on average, how many days supply are they getting? 31.2. And then the drug mix section, we've already covered that in the prior slide. And then the savings section is really showing the value of Navitas. So the network discounts, what that means is we contract with pharmacies on our clients' behalf, and we're a bigger entity, so we can get you better discounts off the average wholesale price, which is what the manufacturers charge for the medications. There was 3.4 million in savings that Navitus was able to garner for the trust. So it was 5% more than the year prior, so that's wonderful. And then rebates. Manufacturers do offer rebates on some products, so that's an important part of what saves you money as well. And you can see you got over $1 million in rebates this last year. And then the next item is actually called Access Guidance Services Today. It's a program where you take manufacturer's assistance. You know how manufacturers will offer coupons sometimes, and the members will take them to the pharmacy. We have a program that actually brings that savings in so the trust can see savings from that as well. So that program offered great savings as well, $152,000 worth of savings from that program. So that's really great that you all, at Gallagher's recommendation, adopted that program. And then the drug spend, just in dollars, what the member paid, again, what the plan paid, or the trust, and then that per member per month figure. And then this slide here is just showing of that program I was talking about, that copay assistance. These are the drugs that your members utilized last year that had copay assistance, just kind of broken out, and you can see again that overall savings of $152,000. And I will turn it over to Brian.
Perfect. And this is my first time in front of the group. I'm Brian Espinoza, the clinical account executive. I replaced Jake Bull, if you guys remember him. But here we go. So this slide's always pretty busy. What I really want to talk about here is your generic dispensing rate being above benchmark. The group is at 87%. Our benchmark is 84.1. So the numbers are looking really good. I usually focus on the last 2 points as well, where it's talking about the average plan paid per brand script, where that's $538.74, which is 5.2% less than our benchmark. That's a good thing. The other one is the generic dispensing rate, and the average plan paid for that was $8.47, which is 40.8% below the public sector benchmark. So that means generally you're spending less on these drug categories. This next slide is the other slide that the groups love. Here it's just showing that a majority of the scripts cost the plan less than $25, but only make up 2.3% of the total plan paid. 1.5% of the scripts cost the plan more than $1,000, but make up 60.2% of the total plan paid. So a small majority of the scripts are making up what the plan is paying.
Brian, going back to what the chairman said, do we know what percentage of these or how many of these prescriptions are not generic brand?
Yeah, so what's going to affect the plan the most is going to be the specialty drug spend, which I'm going to get to later on in the slide. The issue with this is that with this group, the utilizers are, for the drug, it's usually 1 or 2 utilizers, which makes it hard to talk about because if it's one member of the group, it's easily identifiable, right? So we'll talk about that a little bit. There's rebating that also affects the pricing. So when you get a rebate, it lessens the price. So we can look at that too. Does that answer the question?
Not specifically, but I'll wait and follow up when you get to the specialties.
Okay. And I think what you're asking is what percent are brand versus what percent is generic?
Right.
Okay. So here, let's go back.
Of the percentage that we're talking about here, what
Yeah.
percentage of those? Yeah.
Yeah, so 87% would be generics.
But do we know out of the 87%, how many of the remaining were non-generic?
So it'd be
Or were specialty where there's not a generic?
the remaining 13%. Yeah. And then let's go back to Lisa's slide here. The specialty plan paid of that would be 49.2%. Is that okay? And we can talk more after, and I'll clarify that point if needed. Okay, perfect. So now I'm talking about the non-specialty drugs. So these are going to be things that you see for diabetes, things that you see for high blood pressure, things like that. For the plan, it's been pretty consistent year over year. Your top 10 has stayed the same. Anti-diabetics are still number one. The last time they presented this, anti-diabetics were number one as well, and it made up 17.3% of the overall plan spend. Medical devices were not in your top 10 before. They were ranked number 15, but they jumped up. This largely had to do with increased use of the continuous glucose monitors. So think like Dexcom, that monitor you wear that gives you your blood sugar reading in real time instead of having to poke your finger. That was the biggest impact. Any questions on this slide?
So I'd add a question before we got to the slide about the role of the plan in vaccinations. So now, maybe I'm unique because I'm on Medicare, but so a lot of my vaccinations are going to be covered by the federal government or through a qualifying plan. Are there vaccinations that are in fact free to the members and their dependents?
Yeah, exactly. So preventative care vaccines are at $0 cost to them.
So I guess what I'm asking is, what are the vaccinations that are not preventative care?
There wouldn't be any that are not preventative care.
What?
There would not be any that are not preventative care. So what I'm thinking about now is like the COVID vaccine. That's what we get the most questions on. That's at $0 to the member, $0 cost to the member.
Okay, but not $0 cost, obviously, to the county.
Yeah, exactly, to the
I
county.
see the number for the vaccinations. Maybe I'm just thinking as a Medicare recipient, where my vaccinations are frankly free. Okay, but they are to our members too in the plan.
Exactly.
Okay, I'm cool.
Okay, perfect. They're not free to. Well, you guys are paying for it, but they're free to the member.
Correct.
$0. Yeah,
Correct.
copay on that.
Obviously, vaccinations in most cases prevent illness.
Exactly. And then here, it actually goes into the drug mix. So Mounjaro was ranked number one. This is an anti-diabetic medication. It was ranked number one before. It's a GLP-1, which is the hot topic that everybody's talking about right now. It made up 6.9% of the overall plan spend. The other GLP-1 being Ozempic on the group. So they make up the number one and the number two position of your anti-diabetic drug spend. And there's a drug mix table that'll go into that in the coming slides.
Brian, question. So,
yeah, Ozempic's an anti-diabetic. And then the other thing I wanted to clarify with that, Ozempic, the only way you can get it through us is if there's a type 2 diabetes diagnosis attached to it. So that's sort of helping utilization.
exactly. I'm sorry, go on.
No, perfect. Vybersi had the largest plan paid per member per month trend of 81%. This is a drug that treats IBS. This is everybody's favorite slide usually. This is the rebating that the plan gets. So due to the impact on rebates on the top 10 categories, it reduced the plan paid by $680,000, which accounted for 44.3% of the plan paid. The combined savings overall on the anti-diabetic category was $522,000. This is the drug mix table that I was talking about, looking at the anti-diabetic drug mix table. Really, why I added this slide is for the table that's included in the bottom right-hand portion to point out this trend that's happening across most of the groups. Mounjaro increased from 20 utilizing members to 39 utilizing members, which is you're doubling the amount of use on a high-cost medication. And then Ozempic had a similar trend. There was only an increase of 2 utilizing members, so from 25 to 27, and the rest stayed the same. But again, really what this is highlighting is that these higher cost anti-diabetic medications are coming, they're hitting the plan harder year over year. Any questions on this? Okay, so now we're going to jump into specialty. These are going to be the really high cost claims. Chronic inflammatory disease, which is like psoriasis and those types of conditions, cost the plan $250,000, which was 29% of the plan spend on specialty conditions alone. Pulmonary arterial hypertension had the largest increase in plan paid per member per month of 267%. If you look here too, you're utilizing members. Sorry, go ahead.
Sorry. Thank you, Mr. Chairman. I would like to take you back. That is a significant number. So going back to the previous slide with Manjaro, the utilization went from 20 to 39. That's doubling. That's one short of double.
Exactly.
Did anything change with the medication or the accessibility to it or the benefits that made physicians prescribe it more? I mean, our population, our employment pool has not changed in such a way that we would double. So my question would be, what caused it, if we can understand it, if you can shed any light on it? Because it's more of a, your physicians, either the medication changes to becoming more beneficial to more patients or something. And I couldn't help but ask the question, and I don't know if you can shed some light on it.
Yeah, it's a good question. So it's a shift in the way prescribers are thinking. GLP-1s in general, so Mounjaro, Ozempic, Trulicity, are coming sooner in therapy because of the other benefits you're seeing. So you're seeing things like, the sister drug Zepbound, which is used for weight loss, have a positive effect, right? And if your patients if you're thinking of this from the doctor's perspective, if you have a patient who's overweight and qualifies and is type 2 diabetic and has a drug like this that will target two problems, which is the weight problem and then the diabetes, they're more likely to prescribe this to get them to also lose weight, right? Because then they'll be less insulin resistant. Their condition might get better. So really, it's that shift in thinking, because you're seeing metformin use, which used to be the number one drug for diabetes. You're seeing that use go down, and it's jumping into the use of these GLP-1s, so Mounjaro, Ozempic, Trulicity. What we're doing to curve utilization on these high-cost drugs is adding that restricted diagnosis edit, so that somebody who wants to get one of these drugs off-label for weight loss can't get it. The doctor has to submit saying that the member has type 2 diabetes to be able to get Mounjaro, Ozempic, and Trulicity. And that's what we're trying to do to curve usage on it.
Member Bancroft, did you have a question? So obviously these 4 drugs are being used for weight loss, which is probably the reason for the increase. I think that's what you just told us.
It's being used for type 2 diabetes with weight loss as a secondary thought, because you can't prescribe Mounjaro, Ozempic, or Trulicity for weight loss. Mounjaro and Ozempic have their sister drug, Zepbound and Wegovy, which are indicated for weight loss. So basically what I'm trying to say is that the safety net for the plan is that we're doing the restricted diagnosis, so the members that are getting it now have to have type 2 diabetes. So the doctor or the nurse practitioner or the PA has to submit saying they have type 2 diabetes. So I would say, unless the prescriber is, willing to risk their license to say my member has type 2 diabetes when they don't, to only give it out for weight loss, that's the only way they would get it.
Okay, so I'm guessing we're not going to see Wegovy on this list somewhere.
No, the plan does not cover a weight loss GLP-1, so you will not be seeing Wegovy. You will not be seeing Zepbound. Okay,
so that's going to answer one of my future questions, which is what doesn't the plan pay for? I mean, I don't need the list, but
yeah, exactly.
Yeah.
So weight loss as a category is excluded with no path to coverage. So if anybody in the plan wanted to get Zepbound or Wegovy, even through an exception to coverage, it would not be covered.
Good answer.
Perfect. The other thing I did want to highlight here, since we're back on the topic, is the plan script, the plan paid per script doesn't show rebate dollars. So you're seeing the script is $1,200 for Mounjaro, $1,100 for Ozempic. Rebates bring that price closer to $600-700 for Mounjaro and $400 to $500 for Ozempic. So we can't attribute rebates. We can't tell you, hey, this rebate went to this. But generally, when you see that number in the anti-diabetic rebates, that brought it down from 522,000. It's largely due to the rebates on the GLP-1s, if that makes sense. Perfect. And again, so any other questions before I move over to specialty? No? Okay. So specialty conditions, again, just to bring attention to this here is there's one utilizing member for a majority of the categories. Usually I don't hone in on things because of that easily identifiable data. Trikafta was ranked number 1. It made up 8.8% of the overall plan spend, and UpSummit had the largest plan paid per member per month trend. Both of the drugs have one utilizing member, so I'll leave it at that unless there's questions.
What is Trikafta?
Trikafta, this is a medication that's used for cystic fibrosis. So it's a really important one, not to say that any of these other ones are less important, but when you do see that medication, it's usually a member that's going to be on it for a majority of their life. So
It's obviously life-saving.
all of these are life-saving, I would say.
Understood.
Perfect. And then here are the rebates on them. So the top specialty condition was chronic inflammatory disease. So think of like psoriasis, things of that nature. Due to the impact of rebates for the top 10 categories, it reduced the plan paid by $350,000, which accounted for 29% of the plan spend. The combined savings for rebates and manufacturer assistance for chronic inflammatory disease reduced the plan paid by $350,000.
We have a question. Go ahead.
Thank you. Going back to the last slide, are any of those generic drugs, or are there a generic drug for them?
No, there isn't. So the one that I would have expected to see would have been something like Humira and the biosimilar adalimumab, but neither of those drugs made it on the list. A competitor in that market is Skyrizi. Skyrizi right now does not have a biosimilar. So these are different than generics because they're I don't want to make this overcomplicated, but basically with specialty drugs, you look at biosimilars, which is their equivalent of a generic, but there wouldn't be any biosimilars for these.
Okay, thank you.
No problem. For next steps, the one I talk about is the medical carve-out. So we had a return on investment analysis done. However, I was expecting it to not be in by the time we had this meeting. We did get it in, and we talked to Stephanie and Amanda about it. So they might have already presented it to you, and I'll leave that to her. If she hasn't, we'll bring it up next time we're in front of you. And then Lisa has something to say about the access guidance with the GLP-1s.
Sure. So I was talking about the manufacturer's coupons that can bring savings. So the savings that you've seen already is in the specialty category. So we've also just expanded that program to include GLP-1s, which are those weight loss medications. So that is something that the plan could consider as adding to that manufacturer's assistance program. And we're currently communicating and dialoguing with Gallagher about that for the trust to see if they believe that that's a good fit. So we're having more conversations with them, and they'll be getting back to you, I believe, on those recommendations.
So I did have one question from my notes going over the binder. The role of mail order prescription, is it part of our program? Do we incentivize our employees to go that route, which generally seems to be less expensive?
So mail order is a small percentage of the utilization. That's typically what we see because today Retail 90 is very popular. So members can also go to the retail pharmacies and get 3 months supply. And that is advantageous to the trust for pricing as well. So 90 days at retail or mail currently are pretty similar in savings to the trust. So I don't know that you do anything to really push mail, but you do have it with Costco available.
Okay, that's a good answer.
Mm-hmm. And in the benefit fairs, we have flyers and things like that that can talk about ways to save money and mail order and things. So if you ever want pieces like that for your membership, we can provide those as well.
Manager Elders, did you have a question? Oh, I'm sorry. Bring your mic down. Okay. Thank you very much.
All right, thank you.
Thank you.
Okay, I think we're going to move on now to the good news wellness program review. Mr. Hatz, I think you're up.
All right. Good morning, Mr. Trustee, trustees. As you'll notice, I am not Tori Hudson, so I am here as a surrogate to fill in for her and go through the wellness program update. So I'll do the best I can to address any questions, and I have Amanda here as well to provide some backup. So I'm going to just hit a couple key points on the executive summary. So overall, the on-site preventative screenings have held steady. One area that we have seen in the decrease in participation is the health risk assessment. The other categories, cardiac, heart healthy, and flu vaccinations have held steady, but the participation in the health risk assessment has dropped. That's a little bit concerning. We'd like to see people continue to participate in that. Skin cancer screenings, we did not have those this last year. There was a issue with the pricing with the vendor. However, we'll get to this later, that we've been able to negotiate and bring them back on board. So we have that on the agenda for later. So that is good news. Hinge Health continues to be, pretty positive. This is a musculoskeletal program that offers like virtual physical therapy, things like that. That's been very well received. Where we are seeing some issues is Livongo and Navigate. Livongo is treating chronic conditions, prediabetes, hypertension, things like that. It's underwhelming in the enrollment in that program. For example, there are 621 eligible folks with hypertension, and there are 9 people enrolled. So the population as a whole are not taking advantage of the program that's available to them. I'm sure there are other areas of deficits within the chronic conditions that this program can support, and folks just aren't engaging with the program. So there is opportunity there. We will get into a potential replacement program. I don't want to steal their thunder. They're presenting after me, but that is one of the programs that Tori looks at, continuously evaluates their performance, engagement, how they are affecting the program. We would like to see the claims associated with the program that they're designed to support go down or level off, improve. We're not seeing that. We're continuing to see claims continue to rise in those categories. So that is one of the initiatives, is to bring an alternative that may have a more positive engagement with your population. Navigate, which is your wellness portal, is a little bit underwhelming as well as far as enrollment goes. There's 187 users. I believe you have about 1,300, 1,400 eligible. So even just the wellness portal, people logging in, tracking, positive activities that they're doing is not really gained much traction. However, it does seem the group challenges, they do, out of the limited engagement, the group challenges seem to be the most popular. Some areas of opportunity. Again, I think I hit on most of these. A lot of them have to do with the Livongo program that support, blood pressure conditions, high cholesterol, heart disease, things like that. Musculoskeletal, that's always going to be an issue. So I think to continue to communicate and support Hinge Health, and if we continue to see rise in engagement on there, there's going to be positive outcomes. I think that is about it for the areas of improvement. Again, one of those areas we believe could be an area for improvement is looking at an alternative program to Livongo. Again, I don't want to steal these folks' thunder as they're coming on to present here shortly.
I have a question. So when I was looking at this 2 nights ago, the old company I used to work for, now we're talking 12 years ago, 15 years ago, we used to be incentivized with a reduction in our rates to get into these preventative care and wellness programs. Do we do that in our plan?
I don't believe there's currently any participation incentives in place right now.
Should we have participation incentives? I mean, preventative stops the bill from coming later.
It certainly does. And yes, I
I
mean.
would throw that out as a member of the board, that should be looked at. Those who wish to not, and I'm not big on forcing people to do things, that's just not my style. But this is a case where we're paying the bill. And I think there should be some incentive, a reduction of some rates if you get into certain types of programs that have an obvious ROI to us, okay, as the trust, and it just makes sense to me. So I would recommend that maybe we talk this afternoon, that if that's a possibility or not, but I know one way to get your participation up.
Chairman, we will need to have to bring up to the next.
I didn't understand that, I'm sorry.
We will have to bring up that issue up to next board meeting because that's not on the agenda, but we can have the staff look into
That's
it.
fair. At another meeting.
Oh, no, I was just seeing, is there anything else you want me to cover before we transition to D? Yeah, I mean, we certainly do have other clients that have implemented those types of programs where we can bring different types of incentive programs at the next meeting for your review.
Yeah, I think it's a good idea. We obviously have a large at-risk population based on the first presentation we saw. One of the best ways to hold costs down is to incentivize you to get into wellness activities and preventative examinations. This makes sense to me. Let's put it on the agenda for the next meeting.
Will do. Yeah, anything we can do to incent, like Rick mentioned earlier, the decrease in just preventative visits with their primary care physician, that's at no cost. Those are always concerning when you see a drop in visits that don't have any out-of-pocket costs, and then we're also seeing a slight decrease in certain on-site preventative screenings as far as the health risk assessment. And again, those are at no cost to folks. So in addition to incentives, we need to look at alternative communication campaigns and things like that to reinvigorate the population to get engaged in the programs that are available to them.
Let's make it happen.
Okay, so we have Philip with Digby Health who will be going through the next presentation. We're just waiting for him to be patched through.
Philip, are you there? I see you, your picture.
Hey, can you all hear me?
Yes, we can hear you now. So, Philip, if you want to go ahead with your presentation, we'd appreciate it.
Sharing my screen as well here. Amanda, if you can hear me, if we can just do my screen because I've modified the presentation a little bit, that would be great. If not, we can run with one that you have. And it seems that the Mohave County person on the call here is muted, so I'm not going to be able to hear questions. Just want to make sure that that's reconciled before I start.
Why don't you, Philip, if you can hear me, why don't you go ahead and start, please?
Yep, I can hear you now. Awesome. Thank you.
Perfect.
Appreciate you all having me. I've been working with Tori and Amanda on a few different groups across Arizona, and I'm really excited to meet with you all. So I'll be giving an overview of Digby Health today, our philosophy as an organization, and how we may be able to help the Mohave County Employee Benefit Trust. I'll go over some of the science behind what we do. I'll present some case studies from other employers that we've worked with and the results we've seen, as well as some research that we've partaken in with different institutions like the University of San Diego and Northwestern Medical School. I am sharing my screen here, so I'll flip through and kind of start if you if we end up doing the other presentation, that's fine. Just flip through with me if whoever's controlling the slides here. So starting with kind of a brief overview of Digby Health, we have pioneered the use of what we've coined precision biology to address 3 of the top 5 biggest cost categories that we see employers facing today. And those are obesity, diabetes, and digestive health conditions. And our core philosophy is that by addressing each individual's unique biology, we can identify and we can treat the root cause of these conditions. And when we treat that root cause, simultaneously we see 400 other comorbidities that tend to reverse in tandem. So things like hypertension, high cholesterol, even mental health and chronic pain. All of the employees at Digby are on the Digby program. I don't have any chronic conditions. My biggest impact, though, has been reduction in anxiety, being on the program for the last 8 months and correcting deficiencies in my gut microbiome. And I'll share some of the science behind that in a little bit. To give a little more background, though, for years, the healthcare industry has been treating diet-related diseases in isolation, in silos. And you can see examples all around of where that's gotten us. So first, a tsunami of expensive drugs, which I'm sure are a part of a lot of your conversations today. I saw the mention of GLP-1s on a previous slide, and a bunch of digital programs, many of which popped up during COVID and are very expensive and have also barely moved the needle in terms of reduction in claims and bettering outcomes for members. Meanwhile, we have 50 years of science that shows how impactful things like genetics, the gut microbiome, glucose response are when it comes to these conditions. And one recent study, which I can send you all after this meeting, from the Peterson Institute, showed how traditional behavior change programs, which really fail to incorporate the individual and their unique biology into care, have also failed to show any real reduction in cost over the last 40 years. And with high cost claimants being 94% polychronic, it is vital, it's really important to treat each member holistically, and even more importantly, to treat them as an individual and understand that their response to different treatments is going to vary. And again, we call our approach to doing this precision biology, and we've really proven that it can cut through the clutter of digital solutions, the clutter of unnecessary spending that you're probably seeing with a lot of solutions today. So that proof is shown through over 100 published papers, many of which you can access on our website, and over 85 US patents. And the results that we've seen from a number of very large population employer groups, the logos for which you can see on the bottom of the screen here. So what is precision biology? To put it simply, precision biology is using genetic tests combined with glucose monitors, combined with gut microbiome analyses to identify the root cause of a member's condition. And then once we've identified that root cause, provide them with personalized care that is super importantly, simple and easy to adhere to for the long term. Right? A lot of these other solutions in the space, the Virtas, the Vitas, the Livongos of the world, are prescribing mass behavioral change over a large population, not taking into account individual differences. So on top of not taking into account individual differences, there is the idea that this massive lifestyle change is going to be something that's going to be able to be adhered to for the long term, and we just don't see that. I think there might have been a slide skip. If you can go back to the gene nutrition and the gut microbiome report slide. Okay, it looks like that deck is a bit out of order, so I'm not sure which screen you're sharing, but that's fine. You can go ahead and move on. So I think you just skipped it. Go back one. There we go. That's it. All right. So the reason that our approach really works where traditional behavior change programs have fallen short is firstly because each person is vastly different in how they respond to food. So on the left side of the screen here, you'll see some very small snippets of our genetic report on the far left, and then the gut microbiome report, more towards the center of the screen. Again, these are very small snippets. These reports are really extensive, and they're going to break down for the member their genetic tendencies, so towards things like overeating, weight loss or weight regain, but also specific food intolerances broken down to specific vegetable groups, type 1, type 2, type 3 veggies, different types of meat. And on the gut side, gut deficiencies or gut overgrowth, or a lack thereof of certain bacteria in the gut that are responsible for really important chemical processes in the body. So for example, 90% of our body's serotonin is produced in our gut microbiome. So the gut report is also broken down into specific areas like mental health and metabolism as well. So I was super happy when I got my gut microbiome report back and my genetic report back to find out that I was very lactose tolerant. Right, I'm obsessed with cheese, so I can eat all the cheese I want now. You might also find that you're gluten tolerant, right? Or maybe gluten intolerant. But there are these tropes that are told to us on a daily basis that may not actually align with your specific biology, or they may. So what we found is that by targeting root triggers, by guiding personalized changes, it can drive better outcomes, it can lower costs, it can improve long-term health results. And we've seen that in our ROI metrics and our utilization metrics. So we have a 12.2% average utilization, which is much higher than industry average for digital health solutions. And we're reducing claims by an average of $3,421 per member within 12 months of starting the program. And I'll show you later a few case studies. That number grows over time as we, not just reduce reliance on medication for chronic members, but also prevent people from developing additional chronic conditions over time. All right, flip into the next slide here. Perfect. So reducing costs starts by identifying for each employer the biggest opportunities for savings. So we pinpoint controllable high-cost claimants, those dealing with obesity, diabetes, various other cardiometabolic conditions, also GI conditions, who are driving up medical spend through, first off, expensive medications, and you can see some of those medications and the corresponding CPT codes and controllable conditions on the right side of the screen here, and also certain ER visits, expensive surgeries at times. Once we identified those high-cost claimants, we reach out, we survey them for eligibility, and we begin to get them on a path to personalized care and get them on a path to better health. And next slide here, the member's journey begins with a really personalized, very simple onboarding process. So they're going to access the program through either a branded landing page, branded for the organization we're working with, or a phone intake line. We have a really high amount of blue-collar members on the Digby program today, and there are many reasons why we have a lot of success with them. I'll go through some of these in a bit, but one of the biggest reasons is that we're not really overhauling their diet or lifestyle, and we're working around their cultural diets as well as their income level, right? We're not forcing anyone to go shop at Whole Foods and meal prep if they're working in logistics and they're a trucker, right? It's just not going to work. So we target members based on claims data, we survey them for eligibility, and you can see those eligibility requirements in the center of the screen here. So first, they've got to be medically enrolled, and they have to have a BMI of 25 to 30 plus a related comorbidity, or a BMI of 30 plus, or type 2 diabetes, or any GI condition, so GERD, IBS, right? Those would all qualify a member. Now, we do have some groups that want to open this up after year 1, year 2 to a larger proportion of their population. That's fine. We can customize these enrollment criteria. We also have some groups that, for people who don't hit these criteria, they pay for half, the member pays for half. So that's something we do too, but we strongly recommend these criteria because this is what we've seen an ROI with all of our groups for, right? So getting that year 1 ROI is super important before, in my opinion, and opinion of our organization, before opening this up to a larger amount of members. So Once they get enrolled, they take that survey, they get enrolled, we immediately ship out the testing kits. So again, that's a genetic test, that's a gut microbiome test, and a CGM, continuous glucose monitor. We have a research contract with Abbott, and they wear that CGM for the first 2 weeks on the back of their arm, and they continue eating the foods that they've been eating, and we're collecting data on their glucose response to certain ingredients that they tend to eat. They're also going to download the Digby app, and they're going to complete a couple of intake forms on that app, and they're going to meet their health coach. This is a certified dietitian who's paired with each member, stays with them throughout the journey with Digby, and from there they're going to begin tailoring care for that member. Next slide here. All of this testing is done at home, so they don't have to drive to Quest, they don't have to drive to LabCorp. We make it as easy and accessible as possible. So the genetic test is a simple swab of saliva. The gut microbiome test is a swab of toilet paper. And they also get that CGM, the Abbott CGM, that they wear for about the first 2 weeks. We can also manage a CGM prescription for diabetic population. So if they want to use the CGM throughout their journey with Digby, that's something we can help with as well. And of course, all of that glucose or that CGM data gets fed into our app, fed to our dietitians, right? And all of this data plus other optional remote devices. So think wearables, right? I've got an Aura Ring here. Apple Watch would work, Whoop Band, or a smart scale, right? Anything that connects to Apple Health or Android Health can automatically feed data into the Digby app and allows our dietitians, our coaches to make real-time adjustments and ensure members are always on track with their health goals. And again, they're never alone through this process. They have the support of that coach who is a certified dietitian throughout their journey, and they're allowed unlimited calls, unlimited messages with that coach. All right, next slide here. So I think one back, I think you might have skipped over one. Let's see real quick. Maybe not. Okay, we'll just go from here. So the coaches will initially review testing results with their members. They're going to coach them through, why they may have struggled in the past with certain diets or approaches. Maybe they tried to go keto. Maybe they tried the vegetarian diet. Maybe they tried to go vegan, and it just didn't work for them. It didn't stick. So we can look at their genetics, we can look at their gut microbiome data and see clues as to maybe why certain diets didn't work for them. And we're also going to walk them through things that they should focus on moving forward. Big exclamation points in their genetic data, in their gut microbiome data that points to certain intolerances or things that they should be focused on moving forward. And now we can go on to the next slide here. The core of our app is our food analysis tool. I use this multiple times a week. And what this does is it allows the member to simply snap a picture of their food. We then use AI to pull out all of the ingredients from that meal. And it's super accurate. So last week, for example, I took a picture of my bowl, which looked a lot like a rice bowl, but it was actually, I had farro in it, which is a type of wheat, right? Completely different nutrient. It consists of higher amounts of protein, less carbohydrates. It can differentiate farro from rice, right? And different types of cheeses. So it's extremely accurate. We take that list of ingredients from the meal photo and we compare it to the member's genetic data and to their gut microbiome data. And we then provide them with a meal score, a nutrient density score, which you can see kind of in the center of the app there, the nutrient density score at 11. And we then give them 1 or 2 recommendations, small tweaks that are going to drive the most impact based on their biology, their genetics, their gut microbiome, their glucose response to those ingredients. So instead of telling them to never eat this meal again or eat something entirely different, right? We're working around what they're already eating. I'll often take a picture of my meal and get the feedback before I've even started eating, right? So if I need to, for example, add kimchi, because as I often do, or yogurt to a meal because I have a gut microbiome deficiency, I can do that before I even start eating or in the middle of my meal. And by understanding all these differences, it ensures recommendations that align with the individual's biology and recommendations that are sustainable, right? Not overhauling their entire lifestyle. Next slide here. On top of one-on-one coaching and meal analysis, within the app, members also have access to group coaching. They get a full meal planner that is loaded with over 20,000 different ingredients. All of those ingredients rated based on the individual's biology, based on their genetics, based on their gut microbiome. And they get over 5,000 different recipes that are, again, personalized for their biology, personalized to be best for them and what they'll respond to positively. As well as within the app, they get weight tracking, which again can be automatic if they have a smart scale. And for some of our groups, we also send out smart scales. That's an option. Digestive tracking, mental health tracking, and exercise tracking, all within the app. Next slide here. So a bit of research to back up what we've done. So 2 studies you're seeing on the screen here. One was in collaboration with Northwestern Medical School, the other with University of San Diego. And you can pull these studies from our website. So we ran these 2 separate studies that showed how precision care can improve chronic conditions like cardiometabolic conditions, digestive disorders. And then with University of San Diego, it was a study based on mental health. And the findings were really remarkable. So we found that by focusing on the gut microbiome and on genetics, symptom severity decreased, overall health outcomes improved. More than 90% of participants in this study, this initial study, saw at least a 25% drop in GI symptoms and similar reductions in related conditions, bloating, constipation, cramping, etc. And for the mental health side, notable gains in mental well-being, reductions in anxiety, depression, insomnia. And again, this makes sense because 90% of our body's serotonin is produced in our gut microbiome. A large portion of our body's GABA is produced in our gut microbiome. This is why I saw such an impact on my mental health, coming from a place where public speaking was scary for me to being much more comfortable, much less anxious in a period of about 6 months by correcting deficiencies in my gut microbiome. And again, these were all recommended to me by that meal planner and that meal analysis tool. So moving on here, GLP-1 medications are getting a lot of attention right now. And again, I'm sure this is part of a lot of your conversations. I don't want to spend too much time on it. Obviously, I'll state the obvious. They're very expensive. It's also often unclear who's going to respond well to these drugs. And many people stop before seeing clinically significant weight loss. About 30% of people stop due to GI conditions. And then there's the problem of tapering off, right? A lot of people want to eventually taper off of these drugs, but there's no real clear protocols for how to do that. And so it can lead to setbacks. Many patients end up regaining lost weight once they discontinue use of these drugs. And moving on to the next slide here. So to address these challenges, we work with Novo Nordisk to develop what we call the Digby Compass. And this is a model that uses over 20 billion different health data points. We built out an algorithm with these data points that allows us to guide members towards the best path for them. So for some, that might mean solely food as medicine, based on their genetics, based on their gut microbiome. We think we can get them to a clinically significant weight loss solely by adjusting their diet. For others, it might mean food as medicine plus a lower cost medication, like metformin, for example. And then for some, it might be food as medicine plus GLP-1s. So with this algorithm, with the Digby Compass, we can actually predict a member's weight 52 weeks in advance with 92% accuracy, depending on what route we send them down, right? So if we send them down just the food as medicine route versus the food as medicine plus metformin or food as medicine plus GLP-1, what will their weight be? And we can use that to ensure the most effective care route is chosen for them to ensure long-term results that are, again, tailored to each individual's unique needs. I'm going to skip through these next 2 slides here. This is kind of some results, and I'll send this all to you after the call. When it comes to our program options, there are a few different models employers can choose from. And First is everything that I've kind of highlighted so far. It's the lifestyle support package. It's food as medicine. It's focused on treating hundreds of conditions through sustainable changes and dietary guidance. And this is kind of the foundation of the Digby Health Program. It's everything we've talked about so far. Next is clinical oversight and medication management. So this is where we're adding in risk analysis. We're adding in prescription oversight and virtual clinical consults. And it essentially allows us to act as a pre-authorization for these drugs, depending on whether the drugs are deemed necessary, again, through the Digby Compass, discussed previously. And finally, we also have a medication fulfillment option, and that includes pre-authorizations and fulfillment of both branded and compounded GLP-1 medications, and it's up to the employer what they'd like to go with there, but we can do this at a cost that is the same as what a PBM would offer with rebates attached. So a few different options here. I'll be transparent. Most of our clients today are just on the food as medicine portion of this program. And a lot of them haven't started authorizing GLP-1s at all. So I just wanted to run through this real quick. We'll go and move forward now to some employer case studies. So this is a study with our client H&R Block, who's been with us for over 4 years, comparing their employer population on Digby against an identically matched group not enrolled in our program. And over 4 years, as I mentioned previously, the difference in claims cost is clear, and it continues to grow over time. And again, this is driven by a lot of factors. So yes, we improve outcomes for current high-cost claimants, but we also prevent those at risk from becoming costly down the road. We can shift their health trajectory early. We can keep future claims under control this way. And the result is sustained savings that compounds year after year. Next slide here. This is a testimonial from one of H&R Block's employees, James. He came to us and wanted to do this testimonial video. I'll have Amanda and Tori send over the slide deck. You can just click on this and watch this video after. Really cool story. Their group is seeing 13.1% utilization of Digby. They've given us a 63% net promoter score. They're seeing a 7.8x ROI over 3 years on program spend. All right, next slide here. We also launched with Blue Shield of California in 2017 after a human clinical study. And on this screen, you'll see the results for that study. And since then, we've seen incredible results with their members utilizing Digby. So on average, the members included in the study lost 22.4 pounds. They reduced A1C levels by 1%, and they saw remission or reduction in major comorbidities across the board, like IBS, GERD, chronic pain, high cholesterol, and any NAFLD, non-alcoholic fatty liver disease, as well as sleep apnea. We've also offered through 7 other carriers through Solera today. So there's a lot of different carriers that offer us through their through their enrollment platform. All right. What, kind of tying this all together, what sets Digby apart is a deeply personalized approach rooted in each member's unique biology. So again, rather than focusing on a single condition, the care extends across obesity-related challenges from type 2 diabetes and hypertension to GI issues, and it goes beyond one-time interventions. So it's sustainable lifestyle support starting with everyday meals that members are already eating, right? Ensuring that we can make these changes last. And then we have, as I highlighted, the full spectrum anti-obesity program, from screening and prescription through, if an employer opts through it, all the way to fulfillment. And the result is a really truly comprehensive solution that meets members where they are. So closing up here, 3 things that have kind of driven our success with employers. One is being able to treat across multiple conditions. So we're often brought in as a point solution consolidator. Employers have 2, 3 vendors, and we help them consolidate. We help them save right up front initially. 2 is truly personalizing care to the individual and to their biology, instead of putting everyone on the same diet that they may or may not respond to. And this is also where I think a lot of our our engagement comes from. The reason we have such high engagement, instead of blaming the member and their behavior for the problems that they're dealing with, we're offering a solution where they can take a peek into their genetics, their gut microbiome, their glucose response, essentially let them look at the hand that they've been dealt, and then guide them how to best play with that hand, right? So we're not blaming them for their problems. We're instead saying, let's look at the hand you've been dealt. Let's see how we can optimize for that. And number 3 is we focus on sustainable changes to the meals members are already eating, rather than asking someone to uproot their lives, start meal prepping, start shopping at different places. We can work around somebody's lifestyle, income, cultural diet, and even preferences to achieve sustainable long-term results. So that's all I had for y'all, and I'm happy to answer any questions. And I appreciate you all having me.
Philip, hold on. This is Rich Letman, the chair of the board. Do we have any questions from other members? Right ahead.
I believe that you said there was 12.2% utilization. How do you acquire the customers? How do you get them involved? You know, some of us just like to eat.
Yeah, absolutely. So we handle all of the marketing for the employers that work with us. So first we look at claims data to decide kind of who to target. And then we reach out and we run emails, we do webinars, we'll do phone calls if it's deemed necessary for the group, and seminars as well. So we're trying to spread word across the organization about the program. And then, of course, if somebody's interested, then we survey them for eligibility and see if they meet the criteria. Does that answer your question?
Yes, but a follow-up question. So if I take medication for high blood pressure or something, or I don't even know what an overweight drug would be other than some of the ones that we've mentioned, the GP ones. But if I have that prescription and I'm on the plan, are you going to be reaching out to me, or do you reach out to all the county employees?
Are you saying, do we target you based off of your prescriptions, essentially?
Yeah, that's my question. Do you target based on a prescription that I'm getting filled?
Yeah, I don't think we go into that much detail. I think it's more to do with just the claims cost of that member, right? Because there's a lot of PII and other information that we need to kind of worry about there. So in the end, the eligibility is decided by the self-survey and the responses that the member gives. And we target based on claims spend.
Thank you.
Philip, this is Rich Letman again. Of all the material I've had to read over the last 2 nights, this was my favorite section, with all deference to the other speakers.
Awesome.
Yeah,
Thank you so much,
wait till
Rich.
we get into actuarial reviews. Okay. But I totally embrace genetic testing for this purpose. I've had my own food allergy and food sensitivity testing done, which is not nearly as in-depth as what you're proposing. And it has made an amazing difference in my level of inflammation. I'm out hiking again 15, 20 miles a week.
Awesome.
Not bad for 74. Okay, and a lot of it has to do with realizing what foods really caused inflammation. I think this is a great presentation. I loved going through your website last night. I thought it was good. And I hope this is something we as a board consider going forward. I think this presentation is excellent. I like the concept. I see the benefit. I see the reduction in expense and the improvement in people's health.
Thank you, Rich.
You're welcome. Thank you for the presentation. I think we're at the close of your presentation, Philip. Thanks again. Have a great day.
You as well.
We have Casey to come. Is Casey here yet for the... Okay. Casey, come on down and talk to us about teeth and eyes.
Thank you. Hi, everyone. It's great seeing you again. I'm Casey with Emeritus, regional sales representative through Arizona. We administer your dental and vision plans. So I'm going to go through some metrics today, reporting through July of last year through the end of last year, and kind of just talk about these metrics and which network stuff, oral wellness stuff, things of that nature. So first slide here, this is probably one of the more important ones, and I'll kind of loop back to some of the things in here as we go, but this is looking at our dental network. It's looking at the number of claims that are going in network this year versus the prior year, the average discounts on those claims, and then the realized network savings. So when we look at in-network claims percentage, you guys are at 91% for this year. 91 is a really great number. It's above kind of average for the entire state as a whole. You will notice you're at 95% last year. So went down a bit. I'll kind of point out as to why that happened. It's mostly coming down to one out-of-network provider. So in a few slides, I'll elaborate on that a bit more. So that's something I wanted to point out. The discounts on the claims have remained pretty steady, right at about 32%. And then realized network savings, that's just kind of combining both. That's looking at all your claims that are coming in, and then how much did our PPO network save on just all the claims. So it factors in the out-of-network stuff as well, which is why that number is always a little bit lower than your average discounts on those claims. Claims utilization. So this is kind of looking at the spread of where all the claims are going in your plan. Dental plans always have 3 categories, most typically, and then have an orthodontia category if that's a covered benefit, which it is. Preventative, basic, major. The distribution here is relatively steady. We have more major claims this year than we did last year. More people in ortho programs this year than we did last year. We'll dive a little bit deeper into that in a few slides as well. When I kind of looked at where the increase in major came from, it's mostly restorative stuff like crowns essentially was the biggest ticket item there. I think I wrote down you went from 12,000 in crowns claims to 16,000 over this period. So the only good thing about crowns is it's not typically a reoccurring benefit like periodontal gum disease can be. You typically get your crown and then it's done unless there's multiple teeth that need repair. So a lot of times that'll come back down. Ortho can linger a bit. As we'll see, there's more people in programs, so that's something we can kind of expect to linger around for a little bit. The good news is we did have more cleanings this year than we did last year, at least in terms of full cost. So more people are going to get their cleanings. That's good as we talk about preventative work. We want more people seeing the dentist, getting cleanings. They're less likely to get fillings and root canals and then crowns and implants later on. Dental member out of pocket. So I'll spend a little bit of time on this one too, especially this first section where we're looking at the claims usual and customary. So what this is, what usual and customary is on a dental plan, when we have out-of-network coverage, we need to be able to figure out a way to essentially what amount is appropriate to reimburse dentists for when they submit a claim. So when a provider's in network and we have contracted rates, fees with all of them. So if they get a cleaning with us, we might say that you can only charge our members $70 for that cleaning. I looked up Mohave County and the average in Mohave is $100. For just all providers in general, our contracted rate brings it down to $70. So for out-of-network providers, we need to be able to say like what's appropriate, to stop a dentist from charging $200-$300 for a cleaning. So we'll look at a zip code and then we'll say, okay, for this plan specifically, it's the 90th percentile. So the 9th highest charging dentist will cover up to what that amount should be. And so that's what we're doing here. What you'll see on this chart is it's showing, so sticking to our cleanings example, preventative, there's 14 claims that were all $1 over the 90th percentile. So that's kind of what this is showing is that the 90th percentile is sufficient. It's covering the cost for your members. why is there $1, 14 people that are just $1 over? Most likely what a lot of out-of-network dentists will do is they'll try to figure out what the insurance carriers, what they're willing to give. So if they know they've got a bunch of people from Emeritus coming in or any other dental carrier, they'll kind of just keep, even though they might charge on average $100 for a cleaning, the 90th percentile we reimburse up to $120. So they'll keep saying, okay, we normally charge 70, we'll try 80. Okay, Emeritus paid it all. Well, let's try 90. Emeritus paid it all. And so they'll keep doing this until it goes over. So eventually they'll get to 121, and we'll say, hey, we're only covering 120. And so and that's essentially what's most likely going on here. It's probably 1 or 2 dentists because there's only 14 of these claims that have come in. But that's, my point in explaining this is to show that like the 90th percentile is more than sufficient for your members. It's just some dentists are trying to maximize the reimbursement. Does that make sense? The rest of this stuff is just showing kind of where the members' out-of-pocket costs are coming from. I don't need to spend, it's pretty self-explanatory. You've got about 33% coming from the deductible that they pay. They pay a deductible before the co-insurance kicks in, and then 65%, the remaining percent essentially is coming from the co-insurance that they pay with the plan. All right. Member utilization. So this is kind of looking at total claims costs, claims kind of over time, and then we've also got top procedures, number of visits. So some of the main things I want to share on here is we've got average paid claims per employee going up, average paid claims per member going up, so that includes dependents, and then the average amount paid per claim is actually down 7%. This basically means that there's more people using the plan, but the average amount that's coming in is a little bit less. When we look at number of visits, this chart is typically a good one to look at and kind of measure over time. So it's showing spouse, child, employee, how many times they're going and seeing a dentist every year, if they're going twice or no times. So this isn't just cleanings, this is just whether they came to the dentist at all. And what you'll see is 58% of your employees saw the dentist. Of that amount, 43% went twice. So likely the people that go twice, they're either going for 2 cleanings or maybe they had follow-up appointments, etc. But it also means about 44% of your members or employees aren't going at all. That's pretty typical. That's kind of like within range. So it's not too alarming, but I think ideally we get more people seeing the dentist every year to get their cleanings, just to encourage preventative work. In on that, so when we look at the top 10 procedures, that's the graph on the right. The little chart in the middle is just giving you what the codes mean, so they correlate to the chart on the right. The good news here is 7 out of 10 of the top 10 on there are all preventative work. So a lot of times I might see restorative work or something in this top 10, and that's kind of more of an indicator for oral health if people are getting a bunch of fillings. So it is good, at least in terms of volume. This is just number of procedures, not dollars paid, that so much of these are preventative procedures. On to ortho. So I said we'd talk a little bit more onto this. The main thing I wanted to point out on this slide is we had a pretty large increase of people entering active ortho programs. So we had 14 last year, and that went all the way up to 34 this year. Pretty steady on the adult ortho, but for the child ortho, that's a pretty big increase. We effectively over doubled the number of people in ortho programs, children in ortho programs, and those those costs kind of come in phases throughout the year. So we'll expect those costs to kind of remain. The total cost was about, it was $13,000 last year, and we're at $17,000 this year. So that's kind of the figure we look at. That's the increase. But I would say my prediction would be we'd hover around that 17,000 or at least, moving forward or trend up from there, just due to all these new people in the program. Top 25 providers. Okay, so here when I talked about why we had a little bit of a dip and the in-network percentage. So if you see the we've got 23 out of the 25 top utilized providers. This is looking at in terms of paid claims. 23 out of 25 are in our network. The number 2 provider, Ryan there, he's the kind of one that I want to focus on. So he's been on our top 25 before. He's usually down lower, like in the 20s or something. He had a big jump up to number 2 this year. If you look at the number of claimants, there's only 20 claimants, so there's a low amount of people that are using him, but they had some really big claims that are using them. So this also could be one of those providers that's really trying to figure out how he can maximize his allowance from Emeritus. Some things that we've done, we've already identified him and have our provider team reaching out to see if we can get him in our network. So we are working on that. He's been way lower in the past, so we'll see if he sticks around. He might have just had some big services that were needed to get done, and those will phase out. But either way, we're trying to loop both him and Jerry Sullivan to get in our network. Okay, so looking at vision, we'll spend a little bit of time here. Some of the things is kind of just a snapshot of where claims are going, how much claims have come in and how it compares to last year. A couple things I wanted to point out on this was exams are a pretty big chunk under our benchmark, but frames are a little bit over our benchmark. So that's the bottom left square there. Not really anything that's alarming. It's kind of more interesting. I'd guess a lot of people are just fine with the glasses that they have, and they're just renewing them and not seeing the vision provider because they don't feel they need to. So that'd be my assumption and what's going on there. The other thing on here was miscellaneous services was up 15% when we usually see 0.1% on that. So the county's not paying out any of those claims because it's not a covered benefit. It's just those are essentially a code that gets submitted when it's something experimental or some treatment that doesn't fall into our normal categories. So it's nothing that we're paying out on. You can see on the top box there all the way to the right, there's miscellaneous services, and it's 0 because we don't pay anything out. But it is something that's being charged on the plan. And then if we just look at the claims, generally trending upward a little bit, 2%, kind of falling in line of trend. There's nothing too alarming overall there. And then the last slide is just kind of a demographic snapshot. So this is looking at your entire member base. It's showing growth. So we've had about close to 3% employee enrollment and close to 2% on member enrollment. It's showing how many fall into each category, so a lot in that family category. And then it's also breaking down where people are located, what age brackets they fall into, so pretty even distribution across the board, and then also by gender. And that is my presentation. Any questions?
Do we have any questions? Please.
Yes.
Thank you, Mr. Chair. Question is some of the dental utilization claims increased due to any fallout of the pandemic? Like people weren't going to the dentist and now all of a sudden they're going to the dentist again?
That certainly happened. I'd say we're pretty stabilized now from what we've seen, but it definitely, back 2020, 2021, things really dipped, and then we saw kind of a spike as they came back. But we've been, from the groups that I've seen, especially in Arizona, that's all kind of normalized now.
Do we have any other questions? I want to thank you for your presentation.
Thank you. Thanks, everyone.
Before we move to our next one, can we take a 5-minute break? Or just 5 minutes, start the clock running. Okay.
but I know. Set the alarm off.
Okay, we're just waiting for one more member to. That's all right. Well, that's what it was. She to tell us when to reconvene. Okay, very good. We're going to go ahead and resume the meeting. Our next speaker is Bill Oakes. And you're going to tell us about life.
Life.
Okay.
Okay. Okay. Can everybody see the screen? I know it's. Yep, there we go. Okay. Thank you, Mohave County, for having me back again. I've been here the last couple of years. Bill Oakes with Oakes Inc., and on behalf of Securian, your life insurance provider, and also Madison National, your short-term disability provider. I must have went the wrong way. There we go. Okay. I'm not going to get into too much of the plan design, but certainly if you have questions on either the life or disability, ask me about it, and I'll do my best to answer. But I'm going to talk more about your renewal, particularly on the life plan. With the life plan, you are coming out of rate guarantee this year. So on 7/1, the current rate goes away. And so we're going to make an offer today for a new 3-year rate for you, and then you'll vote on it, and we'll see what happens. So, but I'm going to just go over a little bit of how we come about that rate. So what you're looking at is the life insurance claims and premiums over the last 5 years. And I do want to point out, I caught this morning, it says policy year, but it's really calendar year. So that 2024 is the whole calendar year of 2024. Okay. So anyways, these are 5 calendar years. And when we look at a plan, we look at certainly the demographics, how many males to females, what is the overall age of the plan. But we certainly look at a group your size of the experience. So the experience really hasn't been too bad when you look at the 5-year track record. We mentioned the pandemic, and probably that's what happened in 2021, why those claims were so high. But you see that they've stabled out, and so overall, those are not bad numbers when you look at 5 years. Okay. Another thing that we look at, and I might have told this story before to the board, but it's a short one. But you are in what we call our municipal pool. Oaks in 1955, we had 2 counties in Minnesota come to us. They were smaller counties, and they said, you know, if we come together, put our census together, get a little bit bigger, can we get better rates and better plans design? And we took it to our friends at Minnesota Mutual, which is now Securian, and they said, sure. So that started the municipal pool. Last year, we started the year in 2024 with 806 public employers in that pool. At the end of the year, we had 950. So we added a good amount of numbers to the pool last year. And this is the pool that you're in. The number of lives, 250 roughly, 250,000 to about 290. So we added about 40,000 more employees to this pool. So it's the old game of strength in numbers. And so if a group isn't doing well in Arizona, maybe there's 15 groups that are doing better in Florida. So anyways, it's good to be in the pool. You have a little extra protection. It's not just your group that we look at when we look at these rates. So quickly, if these are your current rates, I won't go through them all, but at the top you have what we call the employer rates, what you're paying per month per $1,000 of coverage. So the basic life rate is 13 cents per thousand. You have some AD&D on that for a total of 16 cents per thousand per month. That's what you pay for that 50,000 that you buy for all your employees. And then below that is the voluntary rates, where you allow your employees to buy more if they'd like to. We're offering a 3-year rate hold. So again, no rate increase, 3-year rate guarantee on all these rates to stay the same. So when you talk amongst yourselves, that's what you'll be voting on. Do we want to go into another 3-year rate guarantee with Securian on the life insurance? Any questions on the life insurance before I jump to the disability? Okay. Okay, now I'm talking about the short-term disability. And again, this is employer paid. So the county does buy short-term disability for your employees. This is not in rate guarantee. There's still more 1 year on the rate guarantee, so we'll be talking about that next year. But anyways, there's the rate, 22 cents per $10 of weekly benefit. So again, what it covers is the first 30 days a person is out sick or injured. It doesn't pick up anything, but it starts after 30 days. It pays for 150 days, up to 150 days, or if the long-term disability kicks in. Okay. Any questions on the short term? No? Okay. And that's really my presentation. Thank you for having us again. We really appreciate your business. And as long as there's no other questions, I'll go on to the next presenter.
Thank you very much.
Okay, thank you.
Our next favorite subject, identity theft review. Do we have Shelby and Russell online?
Can everyone hear me?
Good afternoon.
Hi, how are you?
Excellent. Thank you for joining us. Let's go.
Yes, thank you. Thank you for your time today. Sorry I couldn't be there. My name is Russ Tabler. I'm an account manager with Identity Force, a TransUnion brand, dialing in from Baltimore today. So just want to give you some updates on your identity protection benefit. And you can move to the next slide. So here, just a chart that's going to break down enrollments by plan type. Now, please note, this is only for the primary account holders, so this does not include stats for the spouses or children. Currently, Mohave is offering 4 levels of protection, which is including the base level as well as buy-up options for family and premium plans. Now, compared to 2023, there were an additional 10 members enrolled this year. In 2023, we ended with 637 enrollments, with last year ending with 647. This also did include 16 new upgrades to premium plans, with 14 of those being on the family option. Now, to just give you a high-level info on the differences between the two plans, first, I should note that all plans, even the base plan, do cover children. And a member would select the family plan if they want to cover their spouse. The main difference between the two levels is the Plus plan is going to monitor the TransUnion Credit Bureau, where the premium plan is going to monitor all 3 credit reports. Now, moving right along, currently we're sitting at about 38% activation rate for members who have fully registered their account. Now, completing this process is going to allow members to access our website, turn on some of our proactive monitoring features. Now, this is actually pretty close to our benchmark reporting across our entire book of business. Generally, after 4 years, which is how old these accounts are, we see activation at about 40%. So possibly some room to increase those rates. So if you guys are interested, certainly a discussion that we could have in the coming weeks would be some type of registration campaign. We can absolutely get welcome emails resent to the members, and I could even host a webinar if we think it would be a good idea to give some more information to the actual employees, answer some of their questions. I should note that all members are covered through our restoration and insurance features. So if anyone ever has a fraud claim or an identity threat, even if they haven't actually entered in their information to our website, they're going to be fully protected and covered. You can move to the next slide. So on this slide, just showing some of the most common alerts that we delivered last year. Of course, the most popular one is credit monitoring alerts through TransUnion. As I mentioned earlier, this is included through our base package, so everyone does have this. Whereas the 3-bureau credit monitoring, that's only going to be for the premium account holders. Now, the benefit of credit monitoring is pretty simple. Rather than finding out about a fraudulent account applied for after the member's credit score has gone down, they're going to get an alert from us the moment any type of application is processed. We'll also have the ability to lock their credit directly through our dashboard. We also have a few different types of alerts that show what type of pieces of information get compromised or sold on the dark web, whether that's social security number, phone number, email address. But monitoring the dark web is one of the easiest pieces to help members know what pieces of information are vulnerable before they've actually been used to commit the fraud. Now, of course, we don't just monitor for fraud, we also help fix it. So if any of these alerts ever indicate a potential fraud situation, we'll be able to pair them up with a fraud specialist who will be able to handle all steps to get them back to that pre-theft status. They'll be able to file disputes for them, write letters, make phone calls for them, and essentially coach them through the entire process, help out with preventative steps to make sure that fraud's not happening in the future. You can move to the next slide. This next slide just shows alerts and trends that were delivered over the course of last year. You will notice a spike in April, which we do always tend to see around tax season. Surprisingly, we did not see the typical spike we see around the holidays, but obviously there was a large trend of alerts delivered around September. Some of you may have heard about this. There was a breach of over 2.9 billion records from a background check company called National Public Data last fall. This included names and social security numbers and was by far the biggest breach of 2024. Now moving on to the next slide, we've got some just information about what's ahead. So as some of you know, we were acquired by TransUnion, the credit bureau, in 2021. Now, many of the benefits of this are being realized already, in particular with some of the credit resources available. It's giving us immediate access to resolve credit disputes. So when members are contacting Identity Force to help remove fraudulent items from their credit report, they're actually contacting the credit bureau themselves, which of course cuts down on resolution time frame by a considerable amount. And we are also in the process of developing a new platform hosted by TransUnion. There's going to be zero disruption to the members, but there will be some changes that will occur on the back end within the first half of next year. And with that, some new product features will be added to the plan. So again, that's at least 5 quarters away. So we'll have some more information coming as we get a little bit closer to that date. Moving along. Next. This isn't the most exciting update ever, but we got a lot of feedback and found that there was a need for it, so we developed a new billing portal this year. On the last few invoices that we had sent over, there would have been instructions on how to sign up for the portal if you wish. This is optional. The bill still can be paid the way it always has historically, but this new tool is going to allow you to go in, view old invoices, set up recurring payments, and things like that. So if anyone is interested, can certainly set up a more formal session to kind of go over the details on how to use the portal. Next, this is really just kind of an intro slide of something that could be a whole new meeting in itself, but we do have a new feature that TransUnion is making available to all of its clients, not just our Identity Force groups, and this is completely free of charge. Essentially, what we will be able to do is by using only your organization's top line URL. If you're interested, we can provide a full assessment of your organization's cybersecurity performance as a whole. This is totally optional and non-invasive at all. So we're just doing an external evaluation. Not going to be anyone like attempting to phish the network or anything like that. But TransUnion believes that by helping secure the organization as a whole, it's also going to help secure the information of the employees, which of course is our aim. So if anyone in your audience is interested in learning more, we can certainly set up a formal session to deep dive on this new feature. And next, I apologize, this slide might be slightly out of order as this is something that kind of has already been implemented. But we do have some just enhanced credit monitoring alerts that we're now providing through our credit monitoring. So a lot of these alerts are focused not only just detecting when, a new account has been opened or applied for and recognizing potential fraud, but it's also focusing heavy on financial inclusivity, helping members really understand their credit and how different decisions can impact their credit score. So some of these alerts kind of give a little bit more context than some of the credit monitoring alerts had traditionally, and these are already included. So that's about all I have for you. I know I was kind of quick, didn't cover as much of the product 101. I'm not sure if that was needed, but that's kind of what happened last year and what's ahead. I'm not sure if anyone has any questions, but just wanted to thank everyone for their time right off the bat.
Does anybody have questions for Mr. Tabler? Mr. Tabler, thank you very much. It was very informative. Have a good day.
Absolutely. Yesterday, sorry I couldn't join you.
Thank you. Next up, we're going to talk about actuarial numbers. Oh.
You said that so sad.
What a riveting discussion this is going to be. Yeah.
My goodness.
Mr. Marshall, take it away.
Okay. All right. Thank you, Mr. Chairman. Thank you, Board. So yes, as advertised, I'll be going over the numbers here for your plan year beginning 7/1/25 for your self-funded benefits. That's medical, dental, and now vision. So our most important assumption that we use when projecting is trend. So that's kind of our catch-all number for how much we think claims will increase by over the next 12 months, and it differs by coverage. And it also has many components. So there's not only is cost a driver, but also utilization. So if people are using more services, that's not necessarily the price per unit going up, but just more volume. So what happens, or what one thing with that is you see that a lot with prescription drugs. So as mentioned earlier, with nearly doubling with the GLP-1 that was GLP-1s that are being used. So that's a component of that. So for medical and prescription drug, it's on the high side compared to the last several years. It's 9.2%. A lot of that is because of the prescription drugs and these GLP-1s that are gaining a bigger foothold into the overall market share. In addition, you have regular medical costs also going up a little higher than usual, and this is a delayed impact from the COVID pandemic, because there's a lot of contracts and things written, and they were locked into them, and then when the inflation happened, as those go up, so you saw a delayed effect as to when it hit medical, because they had to wait for their contracts to go up. We use for our analysis, we use 24 months of experience for your group for medical and dental. We are only using 12 months for vision right now because we only have we have 12 months and then a few extra months that aren't matured because the plan just started. So next year we'll be able to use 24 months for vision. And just as a reminder, as we go through the rates, that they are only on the claims only. So administrative fees, stop loss fees, etc., those will not be in this analysis. So we will go through on the next few slides the details of these calculations, but just as a summary, for medical we are recommending an 8.3% increase. For dental and vision, we are recommending a rate pass. So good news on dental and vision. Medical RX, it's a little bit less than the trend. But of course, I'm sure not as low as we would like. But that's what we're recommending. On the medical rates, so you can see we have the two columns, and that's the representative of the 12 months of experience that we're using in each one. So 24 months total, 12 in the first, 12 in the second. So it's December 1st through January 31st. We we get those on a per person basis. We then do adjustments based on plan design changes because we want everything to be on as the current plan design. And then we apply the aforementioned trend factor. Certainly.
Note I wrote to myself, I didn't understand what an employee exposure month was. I mean, I think I know what it is, but
Oh, sure. Yeah, it's just somebody that's enrolled for, if they're enrolled the whole year, they would be enrolled for 12 months. So one person could count as 12 in that example. So
the 11,994 are units of months, I guess, is what you're
yeah.
saying.
So if you divide by 12, that's about what you've got, about 1,000 employees.
Okay,
That's what
got
that
it.
means.
Thanks.
So we then do a plan enrollment shift after the trend where we're getting everybody on the same election pattern as the current day. So there's been a shift over time. You get people moving in and out of families or moving in and out of single coverage, or they shift between the two medical offerings, maybe more people in the high deductible plan. And it's just a small adjustment so that we account for that. So at about the middle of the page, you can see projected incurred claims per employee per month. We have quite different numbers with the 12 months of experience. We have 1189 per employee per month, and then 982. So a group of your size, it is big enough to be self-funded, but you can still see fluctuations from year to year. Now, this is a little bit bigger than what we typically see, but it's still definitely possible. So I know in the 12-month period, the first period, the one that 1189, you had more large claims happening, and that was the primary driver for that. The experience was much more favorable for the most recent 12 months. We take the per employee per month amounts and we do a 50-50 blend to get to 1085 and change. We compare that to what your current rates are, which is just a little over 1,000. And the increase needed to get that $1,002 up to $1,085 is 8.3%. So that's how we got medical increase. The next slide here shows just kind of I know can be, the most recent experience you have is really good, so you're probably wondering, well, why am I recommending an 8.3% increase? So the first column is the first 12-month period, which I said had a lot of large claims, so you can see where that turned out. The blue is the actual claims. Then the gray is the additional part that's due to trend, so what we would project for 7/1/25, that plan year. So that's going to be at 1189. And then we have the next 12-month time period, again, actual claims blue, and then the trend is gray. That's 982. Now you can see, even though your plan is running very well, you're right at that red line. The red line is what the current funding is. So if we did just use your most recent 12 months of claims, we'd be recommending a rate pass because with trend, you're below what the current funding is. However, with this group, what we like to do is use 24 months because there are periods, there's ups and downs and ebbs and flows, and sometimes 12 months isn't enough to capture all that with 1,000 employees. So, conversely, if they were flip-flopped, we wouldn't want to just use the most recent 12 months if that was the really high one. So, if you're going to use it when it helps you, you got to use it when it hurts you too. So that's the nature of blending.
So Chris, I have a question.
Yes.
Is trend basically the same as pending claims? I still didn't understand what trend was on the gray bar.
Trend is so if I go to the doctor today, it might be $150. Next year, that same service, same doctor might be $160. So it's the same service. It's just the increase in time with the cost. So as costs go up over time.
How do you track that? I mean,
sorry.
How do you calculate that?
We get information from vendors across the country. So Gallagher actually does a healthcare survey where we get in what for their fully insured business. So this is where the company is actually, they're like your Blue Cross and Cignas and et cetera. They're actually going to be the ones insuring it. They're using a trend, and they are calculating that based off of what they have as their contracts, so they know how much prices are going to go up by the next year, because that's what they've contracted with their providers that are in their network.
Okay, so I'm assuming there's data out there to validate the
Yes.
trend.
Correct. Yes.
Okay.
Yeah.
Okay, thanks.
Yeah. Any questions on medical? So moving on to dental, it's the same process where we have two 12-month period of time periods. The calculations are exactly the same. And here we get a much more, there's more similar result about in the middle of the page, the projected incurred claims. It's just a little under $49 and then a little bit less than $49. So when we blend those, that comes out to $48.87, but your current rates are $51.30. So your current projected cost is below what your rates are already bringing in. So we're recommending a pass. So no increase for dental. And moving ahead to vision, again, we don't have enough experience to do 24 months, so we're just going to use 12. We don't want to use a time period that's not 12 months exactly, because there's seasonality and things that can impact. So in medical, there's more colds and flus, of course, in the wintertime. Something like dental and vision, they're even more susceptible to seasonality, and a lot of that has to do with the fact that people will, when they have, like for the vision plan especially, towards the end of the year, they're going to kind of rush to get their benefits before the end of the year is over or time period's up, or sometimes they do it at the beginning of the year when the year starts out. So it's more susceptible to that. So to just use a 6-month time period in addition to 12, it could skew the results. So we just use the last 12 months, and the formula, the procedure is the same, and we're coming up with $9.23. Current funding rates are $9.54, so you're under, and therefore we recommend a rate pass.
Do we have questions, Manager Elders?
Thank you, Mr. Chair. Chris, understanding your description and your approaches to using 2 years, and I'm going back to the medical NRX, just so you know. I'm curious as to what. So we're looking at the 2 years of 23, 24, and 24, 25. Mindful of the pandemic and the anomalies that came with that, I'm just curious to see if you have 22, 23 numbers. I'm particularly interested to see if that anomaly factors in. If 22, 23 was higher than the 1189 or lower than the 1189, whether the 1189 was a peak or it was a decline from what that pandemic did to all of us. And just the reason I'm interested in it is I want to know if there's any correlation with where we want to go from here. I'm just curious.
Sure, yeah. I'll have to go back and look. If I'm remembering correctly, I think that time period was less than the 12 months ending January 31st of 24. So I want to say 1189 is your high point. I'll go back and check that to be sure, but that's what I'm remembering right now.
Mr. Chair, just a follow up. And that would be great, even if it was lower.
Mm-hmm.
I'd really like to see what that number was. one could explain that as in 21 and 22 we hunkered down, we didn't go to the doctor. In 23 we all kind of caught up and it spiked, and now we're kind of, so I'm just trying to reason these numbers, but
Sure. Mhm. Yeah, I'll get that for you.
Appreciate the questions. Do we have other questions? I don't like the news, but I'm a data-driven guy, and it's hard to argue with data that's soundly based. So I appreciate the presentation.
Okay, great. Thank you. Thanks for having me.
Yeah. We have a question?
Yeah, will you be able to get us that information today?
Yes. Wait. Sorry.
Thank you.
Okay. Yeah. Okay. Our final item before lunch. Numbers.
More numbers. Great. So this is kind of where the rubber meets the road. So we saw everybody's presentation, a lot of the key factors, cost drivers, all of those things that lead us to things that Chris looks at, predicts to the future. Those are the largest variable costs, are the claims. We've heard from life insurance and all the other fixed costs. So now we get into the budget building exercise, and this has a little bit of variability in it. So as Chris noted, the estimated increase to the claims is 8.3%. When we add in all the fixed costs and things like that, which you have a copy of as just a status quo, no changes, it's about 8.4% overall to the budget. The reason of that little discrepancy is stop loss. So that's the one that's unknown right now. As in past years, we do an estimate for stop loss. They typically don't firm up numbers until they have data closer to the effective date. So stop loss has a much higher trend than any other component of your healthcare. It's somewhere between 18 and 22% is the leverage trend, and we assume 20% in our budget as a placeholder. And then when we get that and finalize it, either if it comes in lower than that, then that's great. You have a little bit implicit margin built into the budget, but that's the variable component. Yes, sir.
So, John, could you, for us newbies, define stop loss?
Yeah, stop loss, that's a great question. Is a catastrophic layer of insurance coverage that a self-funded plan puts in place. So they put in place a specific deductible on individuals, say, for example, $200,000. So any claim that goes above, any individual that has claims above $200,000, that claim is insured. And so if it goes to $500,000, you will get reimbursed back $300,000. So the max liability on any individual for any claim is $200,000. Let me confirm what you're at. So you have a $145,000 specific deductible. So any individual that incurs claims higher than that is now reimbursable or insured. So it's basically cash flow protection for a self-funded plan.
It sounds like a form of reinsurance.
It is reinsurance, medical claims reinsurance. It's exactly what it is. So just to clarify, that's the component in here. The memo itself goes through all of the fees that we are including into the budget, but I just wanted to, and I won't go through all of those, I just wanted to note that that's the one that has, is not settled yet. So in addition, so our baseline is obviously status quo, no changes other than some mandatory changes. So there is one small mandatory change, well, two actually. The IRS minimums are changing on a high deductible health plan. Your current high deductible health plan is 3,250 single and 6,500 family. Because of the IRS minimums, they increase every year, and you have an embedded deductible that is going to 3,300 and 6,600. It's very nominal from a budget standpoint to make a $50 change on the individual deductible and a $100 change on the family. So very nominal to the budget, but that's IRS mandated. And then another component is
Mr. Chair. John, what I'm looking at on page 149
yes,
is 3250.65 to 35,700.
yep.
That's not what you just said, I think. So am I misreading something, or am I ahead of you, or am I lost?
No, I'm just completed my explanation. So that's the minimum is 33, but in order to make a larger impact, a proposed plan design change that we're looking at is larger than that to make a little bit bigger impact to the budget if we need to carve some out of the plan. So what I failed to do is put in what the IRS minimum was. So I was adding that, verbally. So I apologize for my oversight. Another change that is happening, and this is again specifically to the high deductible health plan, any teledoc or telemedicine is no longer at zero cost share. So when COVID hit, the government came in and said, even on high deductible health plans where everything is supposed to be subject to deductible and coinsurance, they waived telemedicine and teledoc to say that those can be now used for a certain period of time. That period of time is now ending, so those services will be back to what they previously were, that they would be subject to deductible. Again, very nominal impact to the budget, but just from transparency, just wanted to make sure you're aware of that change. And then we have a list of other benefit options that we had Chris and his team price out. So in case you want to look at, we're at 8.3%, we don't like that number. Is there anything we can do from a plan design perspective to lower the plan's cost? And then we also have built into the budget various options of increases that go from, say, 0 to 8.3%, so we can look at the impact of the reserve position if we go lower than what's recommended. So that, in a nutshell, is kind of the exercise that we do for the next 20 minutes or so. And we do have Amanda here, so instead of just speaking through it, we actually have the model that we can in real time say, okay, here we are at 8.3%. Let's look at, items X, Y, and Z from plan design changes. We can put those in there, and then we can see what the impact of the budget is based on those plan design changes. So with that said, again, we're starting with at 8.3%. Is there anything on here from the benefit options that you would like to see priced, or is the opinion of we're within range where we're not aggressively looking to carve anything out of the plan? I just wanted to get your thoughts on where we should begin. I don't want to go through every possible permutation if it's of not any interest.
I'm going to defer to the county manager.
Thank you, Mr. Chairman. I think overall we're content with the services that we do have. And based on the various reports that we heard today, there's good utilization across the board, some better than others. The one that was prominently highlighted was seems like the Lavingo is not getting as much use. And I heard our chairman describe his enthusiasm for Digby, and I share that, to be honest with you. So I guess my question would be, what if we were to discontinue one and insert the other?
Yeah, and we do have that modeled, I believe, in two different ways. One is a one-for-one. So we remove Livongo, put in Digby. What costs, obviously, we'll save on the Livongo, but there's a price differential. So if we add Digby in, we'll be able to model that delta and how that impacts the budget. And then in addition, we can cover the entire costs of the Digby program almost for dollar, where it'd be budget neutral if you chose to no longer have the Navigate system or portal implemented as well due to its low participation. So we've kind of contemplated both of those components for you to review as well.
Mr. Chairman, thank you, Chris. I guess I can't remember, and I don't remember if Livongo was a component of Navigate. So is Navigate a standalone?
Yes. Yeah. So they're not. So to think of it is we would be getting rid of one piece that just isn't very well utilized, and that's Navigate. That's the wellness portal. They're not integrated or dependent on Livongo. Livongo is a program targeting kind of disease management. And Digby would be kind of a direct one-to-one replacement. Neither one of those is replacing or supplementing Navigate. They're independent of each other.
So, Mr. Chairman, clearly you intimately understand Navigate and Livongo and the intended purpose or functions of those, and then how that would be perhaps not entirely but offset by Digby. The fact that we have Navigate and we have Livongo, and on one hand, and whether Digby covers everything they do or not, I'm not really sure that I can understand that. But what I heard is they're not being utilized. So if they're not being utilized, and we have something, on the other hand, that has the potential of being tailored to individuals to where it'd be more attractive, more exciting, and if you treat the cause, it may affect the symptoms on the other side. So I'm Mr. Chair, I'm in my mind, based on perhaps limited understanding of the two, Livongo and Navigate, and then what we heard about Digby, I would be interested in, again, I don't know what the other board members think, but I'd be interested in modeling that, just replacing the two packages with the one.
I would, and you've got about $130,000 to play with, if I'm looking at the numbers right.
Yeah, so we can bring that up for you and show you with no other changes, just doing what the change in those fees by removing, just make sure I'm clear, removing Livongo, removing Navigate, and adding in Digby.
Sounds good to me.
Yep. Magic. All right.
Anything else? I think we're good.
Okay, and we will be able to show you what that is from a budgetary impact. It should be relatively minor. Cost of two programs compared to Digby is kind of offsetting, so I don't expect it to have a huge impact to the budget, but just anecdotally, we've seen through other clients the Digby present and have every audience has kind of conveyed the same feedback to you all, that it is from all the wellness programs that they've reviewed and they've seen, seems to be one that is finally different.
I agree. Okay, are we at the close of our presentation, or do we have more from Amanda?
We have a giant spreadsheet to go through.
I intend to be at lunch. Okay.
Thousands of numbers, and we're going to go through them individually. So.
Perhaps I see Chris waiting maybe with some numbers while Amanda is getting it up.
I've got that 12-month period before. It projected forward the same as the others. It's 1,052. So it's definitely less than the 1189.
So you're saying in 22-23, it was 1,052? It went from 1,052 to...
Projected to this plan year coming up. Yeah, so that it actually was lower, but when we're adding trend and things on it, it's projected to be 1,052.
Okay. Thank you.
Thank you for performing that so quickly.
Yeah, sure.
Appreciate it.
Okay, so
no finance.
No financial impact.
So basically, roughly cost budget neutral to replace Livongo and Navigate with Digby. One caveat there is I think we're probably being a little conservative as we're putting in the costs for Digby and we're removing the costs for Livongo and Navigate. But what we're not doing is adding in the ROI. As you know, that is population specific, a different group. I know their averages, and I do believe in the power of the program, but I think the crystal ball gets a little bit blurry to be able to put in a number that we're budgeting on. I think it should be, from this purpose, it should be put in as a cost of a program, and then I think will benefit any of the future claims reductions that will go into future projections. Because the proof is kind of in the pudding at that point. I'm not anticipating instant gains.
Okay.
Fair. Yep. I just wanted to caveat that to make sure that, in the spirit of transparency.
Manager Elters, did you have another question?
Mr. Chairman, thank you. I just wish to clarify with Chris the number that you shared, the 1,052, is the blend is the blend of the 3 instead of the blend of the 2 years. Did I understand it correctly? Yeah. 22-23 was 1,052. I thank you for that. Thank you. Thank you, Mr. Chairman.
Bancroft, do you have a question?
John, so considering if we discontinue Navigate and Livongo, is there features or benefits, special benefits, features that they're going to lose with that Digby does not offer?
I think the features that would be at a loss is anybody who's currently utilizing the Navigate Wellness Portal and the challenges, kind of the group challenges that they can get from that would be at a loss. But that doesn't mean that any future wellness portals and things like that couldn't be looked at to bring that back in. But it's, any disruption on that because of the utilization being low is relatively minimal. If it was something where you had, 60% of your population engaging in, I think it would be a much different conversation. But given the low participation in that portal, there will be some folks that probably take advantage of it and will miss it. Mm-hmm. But overall, it's very minimal.
Okay, thank you. Thank you, Mr. Chair.
Any other questions? Do we have anything else to discuss before lunch?
If that was the only kind of option and we're not looking at impact of plan design changes, things like that, I think we're probably pretty good.
Very informative. Thank you. I think we'll go ahead and pause the meeting and take lunch. Actually, we're going to adjourn this meeting. We're going to have another meeting, correct, afterwards? Okay, so we're adjourning this portion. We're going to lunch.
And I told you I would get you back on time, and we did.
Thank you. I appreciate it. I'm going to go ahead and call. Go ahead and call to order the annual trust meeting of the Mohave County Employee Benefit Trust Fund. Madam Clerk, if you could take a roll, please.
Rich Letman,
Present.
Brunel Tillin, I'm sorry. Susie Perel Durasano,
Not present.
Joy Bancroft, Sam Elters,
Present.
and Tingwei Chavez.
Present. But I'm not a member.
Oh, well,
Thank
we'll
you.
take you anyway. Okay, it's all right. Okay, we're going to start the meeting off with a call to public. Is there anyone who wishes to address the Board of Trustees? Seeing none, I'll go ahead and close the call to public. Our first item on the agenda is the discussion, consideration of, and possible action regarding the approval of the trust meeting minutes for March 7th of 2024, March 27th of 2024, April 29th, 2024, May 9th, 2024, and August 22nd, 2024. Do I have any discussion or motion?
I'll make a motion to approve the minute as read.
I'll second.
Okay, we have a motion and a second to approve the minutes as noted. Is there any discussion? If not, we'll take a vote. All in favor, say aye. Aye.
Aye.
Any opposed? Okay, the motion passes. Our next item on the agenda is the feasibility study to possibly join the Northwest Arizona Employee Benefit Trust. John, you're up.
All right, thank you. All right, thank you, Mr. Chair, trustees. So, in previous year, or last year, we did a feasibility study to see if the county would join NABT, which is another, it's a multi-employer public sector trust. It was, at that time, voted not to proceed joining that. We added it to this year's agenda as a item of discussion and an information item to see if that was an exercise that wanted to be pursued again. I attended the February 7th NABT trust meeting. They are certainly willing to entertain the idea of Mohave County joining them, but they have stipulated that to proceed further, they would like to get a letter drafted by the county supervisors to their board of trustees as a consideration for membership. I put a few other notes on here, kind of key considerations, things we went through last year on maybe why you would or why you wouldn't entertain joining a multi-employer trust. I think one of the key considerations is, one of the big ones is a board like this would no longer exist. The county would appoint a trustee and an alternate, and so you'd sit on that board and there'd be one vote versus now you have complete autonomy. Morphing your plan designs, potential disruption to the membership in adopting their plan designs, those are key considerations. Budget stability is one. The larger you get, economies of scale. So there might be some budget stability. As Chris went over, even a group of your size can have big fluctuations over several years. Could eliminate a little bit of that. And then instant access to majority of your reserves would be another one if there was a need for that. Not all of it, because you'd have to fund your IBNR, but your cash balance minus your IBNR, you'd have instant access to that. So those are kind of again, I think the key considerations. There are certainly more discussion topics that you can drill down into. But again, this was just more for information to say that, if you are going to entertain that as an option, NABT trustees would like a letter from the Board of Supervisors requesting that consideration.
Okay, so speaking for myself only, I'm certainly in no hurry to do this. I'm a newbie again, but I do have some questions. Who is in the NAEBT? Is it a lot of governmental districts or some notable ones we need to be aware of?
You're gonna test me on how many are in there. It's not directly my group.
I'm pretty sure Bullhead City's in it.
Yeah, Bullhead City, Lake Havasu City, City Kingman, and Lake Havasu Schools.
So it sounds like everybody but us. Okay, and a couple of school districts in Bullhead City. Kind of. Okay.
But no counties.
Yeah.
And from a scale standpoint, I believe they are combined about the size of the county, maybe a little bit more. So you would bring one entity would almost double their size. And again, that goes back to kind of the philosophical question of...
Might be worth more than one vote.
But those bylaws aren't going to change.
Okay. I had some notes about economies of scale, obviously. One thing that, as I sat and thought this one out, so if we joined the other trust, we would have similar rates, similar plans for similar jobs. Would that be correct?
You would have the same plans and theoretically the same rates unless the feasibility study showed that the recommendation from the actuary was to bring you in at a different rate than everybody else is getting, but theoretically you'd come in with the same plans and the same rates.
Okay, so where I'm headed with this is law enforcement. And I'm assuming sheriff's deputies come underneath the MCEBT. They don't have their own plan somewhere, right? Manager Alters.
Mr. Chairman and board members, I do believe the employee benefit trust covers all county employees, including law enforcement, detention officers, and such. Where they're different is when it comes to retirement plans and so on, but not the health insurance and dental and so on.
Retirement's not part of this.
No. I'm acknowledging that when it comes to retirement and such, they're under a different plan, but when it comes to employee benefits consisting of health insurance, dental, and vision, and short-term liability and so on, they're covered under the county plan.
Hang with me on this. So, as a supervisor, just thinking about this, we just had our sheriff up here a few days ago. Let me kill my phone. Anyway, pardon me. Let's turn that off. And he talked about the competition with surrounding jurisdictions. Surprisingly, not surprisingly, Kingman, Bullhead City, and Lake Havasu City, which I believe are in the NAEBT, correct?
Correct.
So at least in one area, it would be nice to know that I'm in a level playing field as I compete for these resources, deputy sheriffs, police officers, etc., jailers, whatever it's going to be, detention. It would be nice to know at least that would be in one area. I wouldn't have to compete in terms of a package given to a potential sheriff's deputy. I don't think that's a reason necessarily to go over to NAEBT, but I certainly think that is one advantage. It levels the playing field on benefits, makes it easier to make this a strict call on pay, work conditions, and gets it out of the equation.
That is a very good point. Attracting and retaining talent from a total rewards and a benefit standpoint, you do create parity across different organizations where benefits doesn't really come into that decision. But again, you don't necessarily have to join NABT to achieve that, being on your own and having the autonomy to design your benefit program. You can implement a benefit program that aligns with theirs and kind of eliminate or close that gap on your own as well. So having the freedom and the autonomy to do that is one avenue that you could explore, along with joining them and weigh out the pros and cons.
Understood. Manager Elter, is it probably appropriate for you to, if you have any comments on this subject? Again, mine are very preliminary. You've been at this for a while.
Mr. Chairman and board members, and I think we, to you, this will sound familiar because we discussed it last year with our former chair, who had been the chair for a lot longer than I had been here. And I think it really boiled down to a couple of key points. One is we have an employee population that we think is somewhat unique on one hand, and the other is our ability as a board to, represented by various districts and with one board member on this trust board, as well as representation from the employees pool, to discuss, debate, understand, state our needs, and balance our cost to benefit, and that having that autonomy, I think, Mr. Chairman, it really came down to that. And I will tell you, I was in that camp that said, as a board, having the autonomy to look at our revenue stream and what we can pay for and subsidize and what the employees will pay versus the members of the NAEBT. What I also recognize as perhaps a unique difference is they have sales tax. Their budgetary situation, their status is a bit different than ours, and what we contemplate annually and settle on may and may not be consistent with theirs. And if we have one member on a board where we just have one vote, that was a concern to us. So I don't know. I hope I captured what we discussed, but please weigh in. I think Vernell has been here longer than I have to.
No, I think you've well stated it. Did you have a...
Yeah, I just have a couple other little things, and I think one of our biggest in the previous board decision was one vote versus all the other votes, because regardless of how big their school district were or their cities, they each had their own vote as well. But in addition to that, I think one of the issues was, if I recall, and maybe I don't recall as much as I used 2 years ago, but we had wanted or considered joining years ago, and they didn't want us. And now that we're more stable than maybe some of them are, now they want to bring us in, and we just tossed it around several times and just weren't interested.
Katz, I think since the direction of the board is probably won't pursue this year. Safely put? I think so.
I agree.
Okay, let's go on to our next item. And that will be the discussion, consideration of possible action regarding the financials through December 31st, 2024. Mr. Moran.
Chairman, I'm sorry, we might need a vote on the number.
We need a motion on item 3. I don't think so.
It just says to business to come before the board, discussion, approvals.
I don't believe there's any action to be
Yeah,
taken
no
on item
action.
3.
Yeah, no action is fine.
Okay, no problem.
Okay.
Morning, it's yours.
Thank you, Chairman, board members. If I could get the slides up on the screen. Okay, so just a very quick walk through looking at last fiscal. Well, I'll start with the cash flow. The top of the screen there is our cash flow through December 31st of calendar year 2024, finishing the year just under 12 million. That first half of fiscal 25 was a net positive of about 800,000. We started ending June at about 10.9 million. So good news there. If you look at the bottom half of this slide, this is our fund balance through the end of last fiscal year, so through June 30th of 2024. We were sitting just above our recommended reserve for last year, and we are projecting at the end of the current fiscal year to be sitting just above 12 million for the trust fund balance. And so the big question, the big unknown is where that actuary's recommended minimum reserve is going to come in. We get that information towards the end of the summer. So that's kind of the big question mark that we're always dealing with as we look to the next budget year and setting the budget. If that 12 million-ish fund balance is well above the actuary's recommended reserve, or whether we're a lot closer to where the recommended reserve is. It was 9.6 million for the current fiscal year. But the year before that, it was, I believe, just above 8 million. And so it was about $1.5 million increase from one year to the next. So if we see a similar increase going into next year and our projections hold out and we finish just above 12 million, we'll still have a healthy margin between that recommended reserve. But it's a big unknown at this point.
When do you start getting nervous about the balance? Like 10% cushion, 15%, 5%?
I would say that
Over 9 million, that's a nice cush.
Chairman, right now I'm not nervous because what we're projecting, I mean, the recommended reserve would have to increase by several $1 million, which would be a larger increase than I think that we've seen in recent history. That would be Chris.
Chris, come in with a good number.
Mr. Chair.
Because I point to the back.
Answer Elters,
No problem. Thank you, Mr. Chairman. FY24 recommended actuarial reserve was 8.9, was it not? Or 8.8? It was not in the low 8. So the swing from 24 to 25 to the current actuarial reserve recommendation of 9.6, I'm thinking that was under $1 million swing, not more. Luke, am I?
What I have for fiscal 24, Sam, was that our actuary's recommended reserve was 8.18. If you move forward a few slides to the budget, it's on the last page of the budget down at the bottom. Here, I can put it up on the screen.
Yeah, I see it.
So that second column there, 2024 actuals, the recommended reserve was 8.183.
Okay. I for some reason 8.9 is floating in my memory bank. Okay.
Moving on.
And so this slide just shows where we're at through the end of calendar 2024. Before we look at that top chart, I would just direct you to the small box kind of in the middle of the right-hand side there. That is their fiscal year to date, and it's looking at fiscal 23 and fiscal 24. So you can see that there was a pretty hefty increase in claims, about 2.1 million. But right below that, looking at the calendar year claims, the claims paid in calendar year 23 versus calendar year 24 were pretty much flat. And what we did see was that in the second half of calendar year 24, we saw about a $600,000 decrease compared to the prior calendar year. And so that is certainly feeding into, all of the projections through the end of the year. It's positively affecting our budget and creating budgetary savings. And so I just wanted to point that out real quick. The rest of it, the chart here is just showing over the last 3 years, claims versus claims plus administration. And so we've seen marginal increases, particularly from calendar year 23 through calendar year 24. Moving on to the budget, I just want to point out a few things. And so I'm primarily going to be speaking to this 2025 GBS projected column right in the middle of the sheet. To the left of that was our 2025 budget. And so you can see on the revenue side, we're projecting now about $500,000 more in insurance reimbursements than what was budgeted. So a pretty good pickup there. And then we had about a $225,000 expected pickup on the interest earnings side. The Treasurer's Office investments have been doing far better than expected. We were expecting more rate cuts earlier in the year than what actually occurred.
You're not referring to the orange column, correct? You're one of the black-white columns.
No. I'm referring to the furthest right black and white column.
Got it. And where was that positive side on the revenue again?
So the second line, the insurance reimbursements, we budgeted $1 million. We are projecting about $1.5 million on the reinsurance reimbursements.
Got
it. And then down towards the bottom of the page, the health insurance claims, as I said, we've seen a decrease the first half of this fiscal year compared to the previous year. So we had budgeted about $15 million in claims, and the actual projection through the end of this fiscal year is coming in just under $14 million. And so that's going to create some significant budgetary savings for us. On the next page, similarly, I just bring it down to the total there under that charges for services, which the claims is a part of. You can see we're coming in about 1.1 million lower than budget. And so we're seeing positives on the revenue side as well as coming in under budget on the expense side. The net of it down at the bottom of that page is about 1.8 million net positive.
I have a question.
Yes, Chairman.
On the health insurance claims line, that account 998043, the big one.
Yes.
So we're projecting the 13.813 million, okay, in the claims, and then I immediately look over and we're almost 2.7 million higher going into the new fiscal year. Is this because we're just being prudent?
So
is it because there's a number hanging out there that we need to be aware of?
John, I don't know if you can speak to that better than I.
Why is there such a variance?
Yeah, I can add a little bit of context around that, and so can Chris. So when Chris was going through his projections showing how the current 12 months he was using was quite a bit lower than the previous year, and he was blending those two to get a future number. What Luke is showing you is that actual, that we think the actuals are going to come in at, is taking into account only 100% of that emerging experience. So we think it is running better than expected. So that future number is taking what Chris recommended and using that 24 months and blending it, thinking that it will go up, so we don't take the best experience and say you're going to constantly be lower than projected forever. So he made that adjustment to where that recommended comes in at that 8.3% increase, and that's what's reflected in that number. That's why you're seeing that jump back up. It's a blend of those two 12-month periods.
Oh, that is conservative financial planning. I kind of like it, actually.
Chairman, I will also add, if you look on that same line item at where our actual expenses came in 23, they were about 14 million. They jumped up to 16.4 in 24. So the projection for next year is just slightly higher than last year. And as John said, thinking that this year may be somewhat of an anomaly.
Okay.
Because we know that health insurance costs over time are absolutely increasing by at a pretty good
Could
clip.
not agree. Apparently 8.3%. So we have a conservative projection from the actuarial. Plus we have money left over that we didn't use in this one. So it sounds to me like you've got a pretty good cush for a bad day.
Yes, Chairman, that is correct. If we look on this last slide, you can see when we budgeted for fiscal 25, we were expecting to have about $1 million more than that actuaries. Last year when we put together the 25 budget, similar to this year, we were working off of the prior year's actuaries recommended reserve, which was at 8.2 million. And so we worked our budget out to give us about $1 million cushion. But our projections now, because of the positives on the revenue and on the expenditures, we're projecting to be about 12.3 versus that recommended reserve of 9.6. So it's a very healthy cushion. But again, it just depends on where the new reserve comes in.
Okay. That's all right, Chris. You're good. Okay. Okay, got it. I feel a little better going into this conversation. Okay, that's good.
And so that is the end of the review of the budget. What we can get into first, are there any other questions from the board members? So what we don't have in the slides, because we were working on these as recently as over the lunch break, you can see in the budget there's 3 columns. And so the first column, the 0%, is leaving our health insurance rates exactly the same as fiscal 25. So no rate changes. But based on what John and Chris are recommending, that 8%, the 8% increase in rates is what is needed to keep the revenues and pace with the expected expenditures. That does not take into account the fund balance and where we finish this year at. And so the tack that we have taken the last several years, when we have seen a funding gap between where we're expecting fund balance and then the revenues versus our projected expenditures, we've taken a measured approach to where 2 years ago we looked at that gap and we said, well, at that time our fund balance was higher than the recommended reserve, and so we said, well, we'll put a rate increase in place to cover half of the delta, pull down the fund balance a little bit, and then see where we stand at the end of that year. And so that was 2 years ago. Last year,
that's a reasonable approach. I like that.
And it worked. The fund balance came down closer to, you saw on the previous slide, on the bottom half of this slide, that we finished last year with the fund balance just about where the recommended reserve was. And so when we were putting together the FY25 budget, we took a similar approach and put an increase in place.
And the approach we took last year, similarly, was to try and minimize the impact to the employees. The county basically shared and picked up a slightly larger piece than what the employees picked up on a dollar-for-dollar basis. So this year, looking ahead, the 8% recommended is probably far too conservative, in my opinion, based on where we're expecting that fund balance to be. So we did mock up a couple of different options that we can consider, and I don't know if we have the camera working or not. Guys in the IT booth.
Just leave it. They will rotate it.
Can we rotate that 90 degrees? And can we zoom in on that? Can we get that zoomed in on? No? Okay. Well, then I'm just going to read off of it. I did not have time to make a bunch of copies of it. I can certainly email it to the board members. But what we mocked up was the top section is just the rates as they are. We looked at closing that gap by 50%, a number of different ways. So one way would be to have about 260,000 covered by the employees and about 375,000 covered by the departments, basically by the employer. Another option that we looked at was, again, closing it by 50%, but having 1/4 of it paid for by the employees and 3/4 by the county. And then another option, again, closing it by 50%, so a 4% increase, with a 1/3, 2/3 split between the employees and the county. And then another option is to only do a 2% increase, which would be 25% of that funding gap, split 50-50 between employees and departments, or closing it 100% and having that split out between the employees and the departments. So there's a lot of different options. It really comes down to what the board is comfortable with as far as how much of that gap do we want to close. And then we can kind of hone in on the different options within that.
Doesn't matter.
All right.
May I?
Please do.
Didn't last year we just put in a percentage? We moved to the employee side?
So last year we saw increases on the employee side as well as the employer side. And I don't have the percentage in front of me, but what we made sure of last year was that the county, on a dollar-for-dollar basis, the county was picking up a larger chunk of the cost. So I think the county's percentage was lower because what the county picks up is a lot more in the aggregate.
Mr. Chairman, I think we got in the weeds last year, to Joy's point, and we partially closed the gap as part of that approach to do something every year to try to stay ahead. We also looked at the fund balance, the actuarial recommendations, and so on. But I think, if I'm not mistaken, it ended up being based on what we had the employee contribute and the county contributed of the cost. It ended up being about 10.5% for the employee and about 23% from the general fund for the county. Looking forward, though, if I may, just zero in and offer some specifics. Looking at the big picture, I do sincerely believe that the health of the trust is priority to all of us, and that health is continued by doing something every year to protect it and to not have large swings that really hurt. So we have done that in recent years. That would be my preference, to continue with that approach. To that end, you heard from Luke and from Chris and from John the factors that contributed to this 8% to this 8% gap. Yet we have a favorable year from this year. The fluctuations appears to be within the norm. We have a strong fund balance. So I don't believe we need to close half of the gap. I think we need to close a bit of the gap. So if we're talking about 8% gap with all the ingredients that went into that number and the factors of safety that I believe are in it, I'm of the opinion and the gut feel that, and consistent with doing something, that if the 8%, if we close just a quarter of it, do 2%, would be a responsible approach to, again, minimize the impact to the general fund, where we could use that, minimize the impact to the employees for recruitment and retention, and at the same time protect and preserve this fund balance, the healthy fund balance that we have. So if we do only 2% of the 8% that it's recommended, and we come back next year and revisit that, and then take that 2% and split it 50-50 to make sure that we're all contributing, we all have ownership, we all have buy-in, and we have skin in the game. So the employees would contribute half, and the general fund would contribute half. And I would like to suggest to this board that we consider a premium holiday, maybe one period or two periods, like in December, just before the holiday season, where again, I hope I'm not digressing here, but Mr. Chairman, in the last couple of years, we have tried PTO buyback just before the holiday, where they get the payment in January. We established some, we considered reasonable guidelines, reasonable expectations, so it would not get overused and abused. It has worked really well. It's only 2 years, but we like what we're seeing. If we can do something along those lines. So we're still closing the gap, part of it, and with the healthy balance that we have, I'd like to suggest to this board that we consider something like that in December, just a premium holiday. It would impact the general fund some, but I think the value of what we get out of it would be worth it. And I'll just stop at that.
Let's make sure premium holiday means they don't pay a premium.
Mr. Chairman, yes, that is my understanding.
On that Plan A, I wanted to go back to one of the things. So I am an employee, but for the regularly hourly employees or salaried employees both, have we announced if there's a planned increase in net pay for employees, some kind of bump in their pay going into the new fiscal year? Because I would think any increase in your health insurance premiums, you'd kind of hope your employer would at least cover through an increase in your pay, maybe.
Mr. Chairman, thank you. We have not made any broad announcements. What we have done in meeting with the departments, with the department leadership, we have said we will be proposing to our Board of Supervisors the 3% for performance pay. And we feel it's prudent and appropriate and we can afford it. And it's truly up to our board to concur. And we have yet to meet with our board members, so we're meeting with you either next week or the week after. But we have not announced that, we never do prior to the board seeing the tentative budget and weighing in on it. The message out there is and Mr. Chairman, if I may, I was just at the county managers meeting last Friday where one of the agenda items was what are counties doing for their employees this year. And in all honesty, it's all over the map. Multiple counties are doing COLAs and performance pay. We did COLA last year and performance pay this year. We feel like given our budgetary constraints, performance pay will nudge us along. It will be better than nothing. And what is in our budget that we will recommend to the board is 3%.
Okay. So employee compensation is another subject for another day, but I mean, I certainly agree with the direction you're headed on that. That makes complete sense. On that option A, that first one, could you repeat what that was?
The first option, do you mean the first option?
Yeah, I think it was you were going to reduce the 8.3 by 50% and...
Yeah, so the first option, and this is closing that gap by 50%. So it's about a 660,000 altogether. That's 50% of the projected shortfall. About 263,000 of it would be paid by the employees, right, and about 375,000 by the county. And so, as a percentage increase, it's a 10.5% increase for the employees across whatever, the way that was calculated was the same percentage increase, no matter if you're on the regular healthcare plan for your employee only, or employee and spouse, or employee and family, or whether you're on the high deductible. It's 10.5% increase across all the different tiers. On the county side, the percentages varied a little bit there, anywhere from about 2.6 to 3.1%.
Okay, so Manager Elters had suggested taking it down to a 2% gap. What are the numbers on that? Do we have that?
So the numbers on that, and this is split evenly between the employees and the county.
Elters, is that what you were recommending? Split evenly at a 2%?
Yes, Mr. Chair.
Okay, let's hear it.
So for the employees, it's about a 12.75% increase across each tier. And then on the county side, it works out to 2.38%.
And what are the dollar impact to the county?
So our largest employee group, whether it's on the EPO or the high deductible plan, is employee only. And so on a per pay period impact, on the EPO plan, it's $5.86 increase. And that's compared to the current rate for an employee on that plan per paycheck is $45.96, so it'd go up to $51.82. Employee and spouse would go from $139 to $157. It's about a little less than an $18 per pay period increase.
Employee and child would go from 123 to right about 139. So about a $15.50 increase, and then employee and family would go from 200 to 225.
What's the net impact to the county? Just a number.
So the net impact to the county, that column did not print on here.
That's all right.
I mean, well, we're splitting this 50-50, so it's about a $640,000 increase, so it'd be $320,000 to the county. Although not all of that is going to hit the general fund because this is across the entire county. So
Understood. Manager Elders, I think I like the plan. I like the idea. You're obviously banking on another good claims year, it sounds like, going into the new fiscal year, but I don't know. Sounds reasonable. I got my support.
Mr. Chairman, thank you. It warms my heart to hear you say that. I let me just be truthful. Just this is my 5th year. While the COVID years were an anomaly, no one of us understood what was going to happen and what did happen. We have not seen the fluctuations that would cause you sleepless nights when we're talking about a fund balance like the one we have. So it really seems to cover the basis. I think it gives us just a little added security and stability. It does not justify a whole lot further this time, and with all the constraints we have with our budgeting process and employee pay and retentions and so on, it really sort of blends together nicely, and that's where I came from, and I'm grateful that you feel like it's workable, something that we can work with. I wonder if the other board members.
I was going to suggest 3%, but I like your 2% better. I'm not happy with the 8% at all, or the 8.4. That's just especially when we've had a good year. I can't justify that in my mind.
Chairman, if I could just offer two things. So I actually misspoke earlier. I was looking at the projections that we had for 4%, so it's actually less of an impact to the county. The 2% is about 340,000, so it'd be 170,000, or yeah, 170,000 to the county, 170,000 to the employees. The other thing, one of the items that was discussed earlier was the Digby product, and as John said, when they put together their side of the budget, if that was implemented, and then the Livongo and the portal, I can't remember what it was called, if those were both eliminated and Digby was put in their place, that's basically budget neutral, correct? And so what John was saying, though, is they weren't budgeting for any of the return on investment on that as a means of being conservative and waiting to see how it played out. But it is likely that will generate some savings if it's put in place, and so that could further assist in decreasing the overall year-over-year expense that we see.
Like it, Member Bancroft.
I was just going to comment to Mr. Elders. I think last year too was the first year that we even passed an increase to the employees for a couple of years. I don't remember that. Yeah.
And thank you, Joy. If I may, Mr. Chair, for multiple years, this trust managed to do well, and for multiple years, and I believe it was 5. Verlin may remember, there was no increases to the premiums of county employees. So as you heard from Joy, the last 2 years, the pressure we were truly facing a need, a mandate to do something, and even then, we implemented in phases, and it seemed to have worked for us.
What actions required on this? Do we make this decision, or does the Board of Supervisors make this decision?
Mr. Chairman, the way we've done it is this board votes, and then we take it and incorporate it into our budget, and we present it clearly to the Board of Supervisors as the recommendation with this board approval, and then we get the Board of Supervisors approval as well.
Okay, so do we need a motion?
Before any motion is made, I just wanted to speak really quickly to the idea of the premium holiday. I think it's important that, as Sam mentioned, that's included as part of the motion if it's something an idea that's going to be entertained, and I would suggest or offer that the motion be worded as something to the effect that we would offer a premium holiday for one pay period around the end of the calendar year, if at that time the trust balance compared to the expenses so far year to date looks like it can support it. That would be my recommendation.
And are we increasing the rate, or are we increasing the fund? What are we increasing exactly? I think I know what we're in terms of a motion. What are we increasing?
Mr. Chairman, if I was to make that motion, I would make it in the terms of 2% increase to cover a portion of the gap, and then the numbers that Luke just reviewed with us verbally would be built into it. It would be for employee only on one program. It will be calculated to where it is clear. It's translated or expressed, I should say, in terms of it's $6 more per pay period or $11 more per pay period, or so it will be clear and well understood. But we would be here. The motion would be a recommendation to increase our premiums by 2% to offset the recommendation, and then to include a premium holiday for one pay period, except, let me say this, I'm going to go against Luke's recommendation to say, I don't want to complicate it, in all honesty. I don't want to say, well, if the balance is above or below. I just want to say premium holiday for 1 year. We're going to do it. We'll come back next year and see, did it work for us? Did it make a whole lot of difference? We'll keep it or we'll remove it.
Okay, so that 2% premium increase that's 2% on the employee, so not 50% of the 2%.
Chairman,
Yes.
maybe to clarify, and we're looking at an overall funding gap. The recommended increase from Gallagher and from the actuary was a little bit more than 8%.
8.3.
Right. And so we're looking at closing that funding gap by 1/4, which equates to about a 2% increase overall in the premium revenue that's expected to come in. So the motion should be to approve the revised premium rates as recommended, and including a one pay period premium holiday. I can read off what those rates would be, and we can read that into the record. That way it's clear, it's in the record.
I have a great idea. We might move on to the next agenda item while you quickly write up may we do that, Madam Attorney? While he writes up the
Chairman,
suggested motion?
we don't really necessary to take action at this point. I believe number 11 we can decide the rates and the budget on the item.
I like
I'll
that.
put something
Luke,
together.
could you have something ready and
I'll have something
just
ready.
scribble it. And yes, we have a
Thank you.
comment.
Just by any chance, does anybody know the holiday or the pay periods? I know that usually once or twice a year, there's not a insurance premium. Anyone know where that falls this year?
I can look that up real quickly. Yeah, there's usually 2 months of the year that have 3 pay periods, and so we split the premiums out over 24 pay periods, not 26. So there's already 2 pay periods. So maybe we'll get lucky. Okay, so in calendar 25, January had 3 pay periods, August will have 3 pay periods, so this would provide some welcome relief if we had a premium holiday in December of 2025.
You're going to put something together for us that we can
Yes, Chairman.
read. And thank you very much for that. Our next item on the agenda is item 5. Discussion, consideration, and possible action regarding reinsurance renewal process. Mr. Katz.
Yeah, thank you. So I alluded to this earlier when we were walking through the budget, that one of the assumptions that we make is the reinsurance premiums. So this is just a recommended motion that trustees approve Gallagher to work with Juliana, the Human Resources Director, to finalize and negotiate the final renewal effective July 1st, 2025.
Discussion? Members? Okay, I'll go ahead and make the motion to approve Gallagher to work with Juliana Demers, Human Resources Director, to negotiate and bind the reinsurance renewal effective July 1st, 2025.
Second.
We have a motion and a second. Vote, please. All in favor, say aye.
Aye.
Aye. Opposed, say nay. The ayes have it. Let's move on to item number 6, which I don't think require action on this. Change of clerks from the Mohave County Employee Benefit Trust Board from the clerk of the Board of the Human Resources Department. Who's going to address this? Manager Elters?
Mr. Chairman, I think this is just a confirmation that the Board of Supervisors earlier this week
Yeah, we voted.
Yes.
approved this. So this is just an acknowledgement that we're making that change.
That was on the
Okay.
agenda.
We changed the clerks.
Yep.
There you go. Okay, let's go to item number 7, which is discussion, consideration, and possible action regarding approval of contracting with Assured Imaging's Women's Wellness, AIWW, for on-site skin cancer screenings.
Yeah, so when we talked about the preventative screenings, I went over one, the kind of the participation, and the one that I hit on that didn't have any participation was the skin cancer screenings, because last year AIWW came in with a contract renewal that was going from about $145 per screening to over $300. It was something, it worked out to about $330. So it was voted on to say, well, let's not engage in that contract and we'll search for an alternative vendor. Unfortunately, there's not a lot of alternative vendors out there, but through our book of business and our other clients, they've came back to the table and have presented an offer to re-engage a contract going forward at $220 per screening. Still quite a bit more than the $145 quite a few years ago, but well below the $300 or $330 that it was. So this would bring those screenings back into the mix. I think they're a very good preventative screening to have, especially here in Arizona. I think they're well participated in. I believe I don't have any hard numbers for an ROI on it, but as part of the benefit to be included as part of those preventative screenings is a good vendor to have. And it was nice to see them make some concessions to come back to the table with something that is more reasonable.
Does the manager elders, does the board have to approve, or the procurement department have to approve such a contract as this?
Mr. Chairman, no, they do not. This is really handled at this. Gallagher goes through all the procurements and the terms and conditions and so on. And if I'll just, since I have the floor, if I may, given our given our employees mix and the value of this screening to our employees and by extension to every family, I think it's great to have it back, and I'm glad it is not. I'm glad it's 220, not 330.
I think it's a great benefit. Any other discussion on this? If not, I'll go ahead and make a motion to approve the contract with AIWW to perform on-site skin cancer screenings and authorize the chairperson to execute the contract following approval as to form by the trust attorney. Have a second? Okay, we have a motion and a second. All in favor, say aye.
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 Those opposed, say nay. The ayes have it. Let's move on to item number 8, discussion, consideration of possible action regarding replacing Livongo with Digby. Mr. Katz.
Yeah, so I don't really want to belabor this one. We had a lot of good conversation, I believe, already on this. We had a great presentation from Digby. So the recommendation is to terminate the contract with Livongo effective June 30th, 2025, and replace them with Digby.
How do we communicate this to the affected employees? What do we do?
Mr. Chairman, I would, historically, all communication goes through our HR, so HR works with Gallagher on the when and who and how, and then we communicate with our employees
Got it.
thereafter.
Any questions for Mr. Katz? If not, go ahead. Bancroft?
No, I'm good. Make a motion.
Go ahead and make a motion, please.
Make a motion that Gallagher's recommendation is to terminate the contract with the Livongo effective June 30th. We move to add Digby program effective July 1st, 2025, and terminate the contract with Livongo and authorize the Human Resources Director to execute Digby contract following approval as to the form by the county attorney.
We have a motion. Do we have a second?
Second.
Motion and a second. Any discussion? All in favor, say aye.
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 Opposed, say nay. The ayes have it. Go on to the next item, number 9.
Chairman, sorry, I just want to clarify, it's only replacing the Livongo, because I believe county manager mentioned 2 programs earlier.
The next item.
That's the next item, yeah.
Okay, item number 9, which is discussion and consideration of possible action regarding termination of the Navigate Wellness Portal contract effective June 30th, 2025. Mr. Katz.
Yeah, so to continue on the same lines of Digby replacing Livongo, this Digby does not replace Navigate, but again, through the lower participation in this program and to help offset the costs for the new program. Again, both of these, Livongo and Navigate, kind of make it a budget neutral move to bring in Digby. So this is a recommendation to terminate the contract with Navigate Wellness Portal effective June 30th, 2025.
Any discussion?
I'll second.
We have a motion and a second. Any discussion? If not, all in favor, say aye.
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 All opposed, say nay. The ayes have it. Let's move on to item number 10, which is discussion, consideration, and possible action regarding the Mohave County Employee Benefit Trust vendor renewals effective July 1st. Mr. Katz.
Thank you. So when we were doing the budget buildup, all of the vendors had either multiple agreements or fees in place, with the exception of 2. One would be Gallagher, and the other one, Oaks So this is to go overview the two that are renewing effective July 1st, 2025, which is Gallagher, and this is in two components. One is our ongoing consulting services, and the second component is the wellness consulting services. So we're proposing a slight increase for 2025-26, and then freezing that for 26-27. So we're offering a multi-year proposed fee contract for both the ongoing consulting and the wellness consulting. So current wellness is $7.50. We're proposing keeping that the same, and then a slight increase in the following year. And as Bill presented for Oaks, he is proposing a 3-year contract at the current rates for both basic life, voluntary life, and short-term disability.
Manager Elters, what's staff recommendation on this?
Mr. Chairman, acknowledging that we're voting on 3 categories here. One of them is the Securian Oaks remaining the same, and the other is for Gallagher. In the current environment of cost increases, I think these numbers are reasonable, and we would support them. That'd be my recommendation.
Thank you for the input. Do we have other discussion? Berlin?
Discontinue.
No, they're the same, but since we voted to terminate them, I didn't add them. If you voted to keep them, their contract would have been up for renewal. So as kind of a placeholder, I did have them on this memo just in case, the board approved to keep them as a vendor, then I would address their proposed renewal on this memo. But since they are now voted to terminate, I did not address them.
We'd remove navigate.
So we can remove.
Other discussion? Do I have a motion?
I'll make a motion to approve the following Gallagher Oaks Securian renewals as offered, and authorize Gallagher to work with Juliana Demers, Human Resource Director, to sign contract effective July 1st, 2025.
Do we have a second?
Second.
Okay, we have a motion and a second on this item. Any discussion? All in favor say aye.
Aye.
All those opposed say nay. The ayes have it. Let's move on to item number 11, discussion, consideration of possible action regarding the 2025 MC EBT budget, benefit changes, and rates.
So we kind of put the cart before the horse, I think, going through the others, because this memo was coming up to address the budget where you all agreed on. So
handwriting.
Stamp it.
Now we can formally do it.
Premium. I think that proposed motion already kind of covers it because it's benefits and rates as decided. I can read the rates into the record if you want me to.
So do. Let's go.
Okay. So the suggested motion would be move to approve the following 2024-2025 benefits and rates as decided upon by trustees, and authorize Gallagher to work with Juliana Demers, Human Resources Director, to sign any contracts for vendors that will become effective July 1st, 2025. This motion also includes a 1 pay period premium holiday to take place in December of 2025, and the rates decided upon by the trustees are as follows. For the EPO plan, employee only, okay. So the monthly rates are for EPO plan, employee only is $103.64, employee and spouse $314.30, employee and child $277.37, employee and family $451.77. For the high deductible plan, employee only is $88.52, employee and spouse, $264.88, employee and child, $235.57, and employee and family, $375.23.
Okay, so I'll go ahead and make the motion to move and approve the following 2024-2025 benefits and rates as decided upon by the trustees, and Gallagher to work with Julianne Demers, Human Resources Director, to sign any contracts that for vendors that'll become effective July 1st, 2025. Motion to include a pay period premium holiday in the month of December, and to you, for the clerk, for using the rates as read into the record by the CFO. Do I have a second?
I second.
Okay, any other discussion? We have a motion and a second to approve. Do we, all in favor, say aye, please? Aye.
Aye.
All opposed, say nay. The ayes have it. Item 12, administrative update.
Thank you. This will be very quick. We're going to be working with the county staff to draft open enrollment communications, as well as requesting the vendor marketing materials for the benefits offering through Mohave County Employee Benefits Trust for this upcoming plan year. This is more of an informational update. So
No actions required on this item. Any discussion? Let's move to item 13, request for future action. I believe this is open to staff and the board. Manager Elters, anything from you?
Mr. Chairman, one item we will put on the agenda is to contemplate, explore, having incentives for enrolling in certain programs and such to as you suggested earlier.
Yes, so let's talk about preventative care and possible reductions in premiums as an incentive. Get that done.
Good.
Any item
Good.
from you?
Nope, I'm good.
I just want to make sure that somewhere on our future agenda, we have a update on our appeal we have going on.
Okay.
Oh, okay.
Okay, so noted. Any other items?
The only other item, not to go before the board, but just to say, while we miss former Supervisor Angus, Supervisor Letman, you did great in your first meeting.
We have a better sense of humor.
We
She does.
we really appreciated you volunteering to run this board, and you did great. Thank you.
Well, let's go get it done, okay? Let's do it. Thanks to all of you for attending today. It was a good meeting. I learned a lot. Everybody have a good day. The meeting is adjourned.